حضراتكم، فشاكرين جدا لكم وإن شاء الله بالتوفيق. إن شاء الله we'll continue, we'll start. Today we will start our second day from our symposium, and I want to congratulate all our colleagues from Saudi Arabia for the Foundation Day, and I wish that it will be a fruitful day, inshallah. Our first speaker today will be Dr. Abdullah Shamrani. Dr. Abdullah Shamrani is a consultant pediatric pulmonology, and he is the director of the program of the Saudi subspecialty pediatric pulmonology. Dr. Abdullah is one of the most eminent pediatric pulmonologists in all Saudi Arabia, and he has a long experience in publication in pediatric pulmonology and in asthma guidelines in Saudi Arabia. Dr. Abdullah will give us today 2 lectures. The first one will be asthma mimickers. Okay, Dr. Abdullah, you can start. وأهلا بك وكل سنة وأنت طيب.
Is that fine? The slide is shared now?
Yes.
بسم الله الرحمن الرحيم والصلاة والسلام على خير الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. First of all, thank you for the organizing committee for inviting me for the 3rd time. A special thank for the man behind the show, Al-Habib Dr. Nabil. I'm really very happy that the first day was really went smooth and the attendees exceeding 700. Inshallah, this day will exceed 1,000. I'm happy that to present 2 common presentations in pediatric pulmonary and pediatric sleep medicine. The first talk will be about the asthma mimickers, and all of us knowing that the asthma is really common in everywhere. It is the commonest chronic condition in childhood, and the asthma mimicker as well, they are even more common. Okay, and there is debate: is this asthma? This is not asthma? And we will see. I will give you some of my archives and simple messages, mainly for the junior. And the evidence here, probably, I would say personal experience, so the evidence here is level D, but I'm sure that it will be beneficial for some of the starter or the junior people or the pediatrician, or even though the health care, any health care providers. So these are the outlines, objectives, introduction, when asthma is not guilty, and common case scenario. So I will give you a real scenario exceeding 10 cases, okay, where at one time we thought that they are asthma, but at the end they are not asthma. And what could be the clinical clues to think that this patient is asthma and this patient is not an asthma, and when to refer to the pediatric pulmonologist, and what could be the home message at the end. Okay, so my objective is to recognize common diseases that mimic asthma. And second objective, I would like to utilize appropriate history and physical examination to reach appropriate diagnosis, and to know when to refer to the subspecialty. I refer you for this article. I feel it is an important article. It is talking about asthma mimicker, but we changed the asthma when asthma is not guilty. And this is published 2 years ago in our International Journal of Pediatric and Adolescent Medicine here. Okay, so I would say it is really very recommended for general pediatric. So if I will give you a common cases that we know that the asthma is presenting with a cough and wheeze and shortness of breath. Okay, and if you look to the X-ray, showing hyperinflation and bronchial wall infiltrate. Is this asthma? So this is a child who is admitted in winter time, January, under general pediatric, with a cough and wheeze and shortness of breath, and there is hyperinflation with bronchial wall infiltrate. Okay, so if I'm asking, is this an asthma? Definitely, colleagues, they will say no. So this is a simple case of bronchiolitis. Okay, but now I will give you another difficult case, and this is a real case founded I observed this case in the King Fahd Medical City at one time. At that time, she was an 80 years, and she was diagnosed to have asthma for many years. Okay, she had frequent admission as asthma exacerbation plus or minus chest infection. She had numerous admission, including at least 8 times to the ICU. The usual trigger is flu. She is not atopic, and the parent, they are saying she is not a good responder to a bronchodilator. And if you look to the X-ray, there is hyperinflation and there is bronchial wall infiltrate, and the presentation is cough and wheeze and shortness of breath and desaturation. So is she asthma? I will show you later the bronchoscopy for this case. Okay, so definitely you will have a big question mark that this patient is not an asthma, and why. So asthma mimicker, they could share the same complaint: cough, wheeze, and shortness of breath. They could share the same physical finding, example, bilateral wheezy chest. They could share the same finding as you observe hyperinflation, pre-bronchial infiltrate in, for example, I have seen it in bronchiolitis or in reflux disease. Oh, and sometimes it will be masked. Okay, is patient sometimes good responder to the asthma therapy? Another report, okay, because wheeze is the main presentation. Some people, they say, wheeze is chest asthma. No, so this is a good an article we published it 2 years ago with the colleagues from military for approach for wheezy kids. You should know what is asthma. Asthma is 4 main components. It is a chronic inflammatory condition. There is hyperresponsiveness to variable stimuli. There is variable airway obstruction, and there is a symptom: cough, wheeze, dyspnea, and chest tightness. Okay, so these symptom is just the tip of the iceberg. Okay, so people just label, oh, wheezy chest is asthma. This is not true. Asthma is a common here in the kingdom, and many years we are depending on the report by Prof. Al-Furayh, okay, that the asthma is around 23%. And I would say there is a recent report by Dr. Al-Ahmadi from Jeddah that the lowest asthma is in Abha, 9%, and the highest in Habu, 33%, and second highest maybe Jizan and Al-Jubail, 24%. Al-Jahdali, Prof. Al-Jahdali from National Guard Hospital, he is alerting people that only 5% of asthma in the kingdom, this is an adult, okay, well controlled, and 31 is partially controlled. And there is a recent report by Dr. Al-Jahdali that the well-controlled asthma is improving from 5 to 31. I have, with one of the intern at one time, published an important report, okay, that 45 asthma in the tertiary center at King Fahd Medical City were uncontrolled. Asthma, it will be really difficult to be confirmed in younger than 5 years. And usually when approaching asthma is younger than 5 years and older than 5 years. Younger than 5 years is really difficult because asthma is a syndrome. It could present like night cough. It could present only residual cough after flu. It could present with recurrent cough or persistent cough. Oh, persistent. We'll come later on about when to say label patient recurrent or persistent. Okay, recurrent we prepare maybe 3, and persistent at least a month. Sometimes the asthma could present with pneumonia, or patient is good responder to the asthma therapy. And then here there is no much help from the investigation. You need to know about asthma predictive index or modified asthma predictive index, and majority of the people, the young pediatrician, they should know modified asthma predictive index. That means 3 episodes of asthma with 3 episodes of wheezy chest. Then one of the 3 major criteria: parent with atopy, parent with asthma or atopic child or positive aeroallergen, or 2 of the minor criteria: food allergy, wheeze apart from the cold, and eosinophilia. And I put from my experience plus evidence, like Jones criteria in the acute traumatic fever. Okay, plus evidence. Patient is a good responder. Anyway, at one time, Cincinnati, you can label asthma with 2 episodes of wheeze, and even Canadian guidelines, tight index and lows index. Lows index, that means patient, you can label patient as asthma if, For example, he's one episode of wheezy chest. He's atopic child, and he's a good responder to the asthma therapy, whether Ventolin or steroid. So this patient, you might label him as an asthma. And in here, there are, I would say, different type of wheezy chest. You don't need to know because the token here is about asthma therapy, whether from the taxon to the LSPAC to the Bayama study. So I will leave these for the subspecialty. Now, kids with asthma or wheezy chest more than 5 years, it's really easy to diagnose asthma because it is a clinical diagnosis. Okay, and you will be able to confirm the patient to have asthma based on the clinical presentation, cough and wheeze, and reversible obstruction and good responder to the asthma therapy. And you can see the scoping and you can confirm it with the spirometry. Okay, and you need, for example, 12% in the FEV1 or 30% in the mid-expiratory airflow, 25 to 75%. Okay, and if the patient is uncontrolled, you can say partially controlled when there is one item is not meeting the criteria for control, like daytime symptom, nighttime symptom. But if you have three feature or three elements being affected, like daytime symptom, nighttime symptom, limitation of activities, already you can label your patient as uncontrolled asthma, and you need to ask yourself why he is uncontrolled asthma. And there is only 5 questions for that. Compliance, which is very common and very important. Technique is very important. Inadequate doses or risk factor like smoke or comorbidity like allergic nose or obesity. If the compliance is good, technique is appropriate, or technique adequate doses, okay, no risk factor, no comorbidity, and patient is still uncontrolled, this is now the asthma mimicker. So what I have mentioned so far, 10 minutes, is still now as an introductory for my talk. And now the diseases that could share the asthma, the R chapter and pediatric pulmonary, could be anatomical, could be host defense, could be post-viral, could be recurrent aspiration, could be perinatal disorder, and could be other like foreign body, cardiac, and others. So I will give you now 2 most important slide in here, when to clinically to label your patient as asthma, and when we think that this patient is not asthma. So asthma, usually dry cough, intermittent, late at night, good responder to the bronchodilator. It is seasonal. It wears after emotional or after exercise or after flu illnesses. But if you have a child with wheat cough, persistent cough, barky cough, cough early at night, for example, sinus, barky cough, this is, for example, croup or tracheomalacia, cough that is fade with the sleep, this is psychogenic, with related to feed, gastroesophageal reflux of aspiration and coordination, okay, nasal discharge, clear nasal discharge, allergic nose, or purulent nasal discharge, chronic sinusitis. And you can see this report, okay, from our report that we published 2 years ago. Now, often in the clinic, asthma child is a normal child. You might see some allergic nose or evidence of atopy, or sometimes you might see wheezy if patient has some recent exacerbation. But otherwise, most of the kid is normal growth. But if you see now a child with clubbing, failing to thrive, you think about non-asthma. Hearing loss, immunodeficiency, or BCD. Nasal polyp, maybe CF, chest asymmetry, foreign body or lung malformation. Localized wheeze, foreign body and lung malformation. Crackles, immunodeficiency, pneumonia, others. Swallowing difficulty on coordination, myopathy, whether, for example, cerebral palsy, Down, neuropathy, myopathy, name it. Now back to the clinical challenge, and I'm expecting now the people, they would like to see the real case. So this is the first case that I mentioned, a child who's an infant less than 2 years and present in winter time with a cough and with a chest, okay, with hyperinflation and peribronchial wall infiltrate. So the diagnosis is straightforward, is bronchiolitis, and the bronchiolitis is the leading cause of admission in the winter time in the whole northern hemisphere. Okay, now the second challenge. So this child is 14 months, okay, admitted under pulmonary with a cough, wheeze, and shortness of breath. And if you see there is hyperinflation and maybe double obesity in the retrocardiac, okay, but in reality, this patient being labeled, this patient treated with steroid till he has cushingoid, and as you see in here, the child is NG dependent, so there is swallowing coordination. We thought about myopathy for this patient. We were not able to prove it, okay, but this patient is refluxing and there is hiatus hernia. So now we will move the third case of potential asthma mimicker, so congenital airway malformation. So the malacia, okay, laryngomalacia, it's upper airway, it's present often with stridor, but the trachomalacia and bronchomalacia, okay, usually bronchomalacia will predominantly with the chest. Trachomalacia is tricky. Trachomalacia is tricky because the upper third of the trachea is above the thoracic inlet, and the child will present with stridor, like subglottic stenosis. So presentation of subglottic stenosis will be what? Stridor. But if the problem in the lower two-thirds of the trachea, the child will, it's intrathoracic, and the child will present with the chest, okay? And there are two types of trachomalacia, either primary, which is idiopathic, and I will show you a case or similar of that one, or usually secondary, either tracheoesophageal fistula or cardiac compression, okay? So now I will give you similar, some cases of malacia. So this patient is a cardiac, and now I wedged in the left main bronchus, and if you see now the left main bronchus, okay, there is a complete compression of the left main bronchus, and the child at one time he with his chest. This patient, he was scheduled for fundoplication, but when I was in the OR, okay, and I have done bronchoscopy, I observed there is trachomalacia as we see in here, and there is a fistula, okay, in the posterior part of the trachea. And you, when I suspect the fistula now, I just press the tummy on the stomach, okay, and I observe is there any bubbles will come back from the lower part of the trachea, and there is an air bubbles comes from the trachea, and we change now the picture from the fundoplication to treat the fistula. This patient, for example, this is this is already I show you that one, because this is the compression of the left main bronchus. But this is lemma. This is an primary trachomalacia, trachobronchomalacia, and tracheal bronchus. I'm now freezing the vocal cord. Now I will go shortly in the left in the subglottic area. Then I'm expecting to see the cartilage, the C shape. Where is the C cartilage? You know, in the Mondial, where is Messi? Where is the C cartilage? There is no C cartilage. Okay, so this is one of the worst trachomalacia I have seen. Okay, because there is no trachomalacia even till I thought that I'm in the esophagus. So this is, as you see, just flat surface of the tracheal lumen and easily compressed. I have, I'm presenting here now a child with a vascular ring, two patients, Abdurrahman and Sultan. Okay, as you see in here, there is bilateral hyperinflation, and the dome of the diaphragm supposed to be higher in the right side due to the pressure from the liver. Oh, in here, the left is higher. Okay, so there is hyperinflation more in the right side. And the cause of hyperinflation in the right side is compression of the right main bronchus. This is Abdurrahman. Okay, vascular ring, as you see in here, with a variant. But the other difficult case, Sultan, I have seen him today. This Sultan, he's 7 years. He remained ventilator dependent, failed extubation 10 times. Okay, in military hospital, as you see in here, I'm in the lower part of the trachea. This is double aortic arch. Okay, then there is 100% narrowing at distal part of the trachea, just above the carina. Okay, and the double aortic arch, in this case, published twice. Okay, initially published as a double aortic arch. Okay. With residual narrowing in the distal part of the trachea, and we stuck how can we help the patient? This patient double aortic arch, the anterior was small, so we ligate the anterior. We try to extubate, failed. So then what we have done for this patient, we have done posterior aortopexy. We pulled the aorta away from the trachea, and after a week that we were able to extubate the child, and this is the child. He remained 14 months ventilator dependent. And now this is, sorry, the picture, I was not aware that it is rotated. This is today. This is today. He's 7 years. He's very smart child, okay? But he still has exacerbation, okay? Now, in this case also, we'll move from double aortic arch or vascular ring to another malformation that present with persistent wheezy chest. 6 months, the child has persistent wheezy chest and recurrent admission, including the BICU. Okay, there is hyperinflation. Now the hyperinflation more where? In the left side, okay? When I have done the bronchoscopy, there is a dome shape of the carina, more pressure on the left side. The carina is supposed to be sharp angle, and in this case, just simple. The problem of the child was bronchogenic cyst, just one centimeter by 1 centimeter just below the carina, making more pressure on the left side. Okay, some people will say this is foreign body. No, this is 6 months and he has persistence, so unlikely. There is no other case introducing foreign body in the nose of the child. Or maybe this patient congenital lobar emphysema. Congenital lobar emphysema, we are expecting hyperinflation in the upper lobe, but collapse in the left lower, so there is no collapse. So this patient is called McLeod-like or Swyer-James syndrome. So this is very tricky, and this case published in the American Journal of Case Report. This is, I received a call one day by the general pediatric. Okay, this patient has wheezy chest, and there is asymmetrical wheeze more in the right side, and there is volume loss in the left side, and this patient has BDA, and they thought there is migration of the BDA device to pulmonary artery causing left lung hypoplasia. Oh, but the smart people, the pulmonologists came and suspect foreign body, and this patient has a missed foreign body in the left main bronchus, and we take it out and the child back to normal. And also this case being published in pediatric ENT journal a long time ago. The other patient, this one on the right side, was in the ICU, status asthmaticus, okay, until the child has really a pneumothorax and a cuffed hair clamp. So again, foreign body is a common asthma mimickers, and you should sometimes should have low threshold for diagnosing foreign body. This patient is 18 months, has cough with and shortness of breath, but he's underweight and clubbed with metabolic alkalosis. So cystic fibrosis is very easy to diagnose. This child, he's 2.5 years, cough with and shortness of breath and treated as asthma. Oh, but this patient has history of adenotonsillectomy and ventilation tube. Okay, and there is purulent nasal discharge and infertility in the family. So this patient is BCD. Okay, another tricky case, this patient 6 years, uncontrolled asthma. This is the CT. So I usually trick the fellows, what could be the diagnosis? So in here, what is the diagnosis? People can pick it up easily. So this is a rotated image. Okay, so this is the pulmonary trunk on the right side and the aorta in the other side. So this is right aortic arch. So this is a mirror image, cartegener, and this is right main bronchus, and this is the left main bronchus. Okay, so this patient is dextrocardia and the cartegener and present with purulent nasal discharge. Okay, and this patient, by the way, he had history of prematurity, so you should think about BPD and bronchopulmonary dysplasia. I will never forget this patient who referred to me by the immunologist. This is Abdullah. This patient has wheezy chest and he's not a good responder to the asthma therapy. So I have done bronchoscopy and I observed that he has Pseudomonas. Pseudomonas is not of the common organism that expected in normal host. So I refer the patient back and proved to have a hypogamma. This patient referred to us from Al-Kharja at one time. Okay, patient was well, then all of a sudden has wheezy chest and hypoxia, and referred initially to the cardiology to evaluate the hypoxia, cleared from the cardiology. At one time I say this patient could have an aspiration. Then I have done the CT, any herbal, no. Then I said there is intralipid proved by the CT, because the CT, there is certain density for the intralipid. Okay, the mother denied that one. Then I have done the bronchoscopy, and the bronchoscopy proved the lipid laden. Then at one time, this patient choked with gishta butter. Okay, at one time, large aspiration could be enough. This colleagues or parent come to me in Hamadi Hospital. He said, Doctor, my kids is about to be kicked from the class. She is continuously coughing for 3 months. During daytime, disappearing at night. And I swear, wallahi, this is a real case, and these are the real medication that being given to this unfortunate girl, okay? So this is very typical of somatic cough, and I have several cases. This child, as you see in here, referred to me, this patient transplanted, by the way, in King Faisal, okay, referred as uncontrolled asthma. He brought to me at one time with these numerous inhaled steroid, and he is uncontrolled. He has some side effect of the steroid, okay? So this patient proved to have bronchiolitis obliterans. As you see, there is hyperinflation as well, okay, and transplanted in King Faisal. Maybe the last two slides in here that still clinical is very important. Persistent moist cough, you should think about CF, immunodeficiency, aspiration, or BCD. Paroxysmal cough, either pertussis or malacia. Cough when related to the feet, either reflux or swallowing problems. Seasonal asthma, purulent sinus, early cough, early at night sinus, clear nasal discharge, allergic nose, abnormal voice, cry, tracheomalacia, laryngeal problems, focal sign for embodiment, history of prematurity, VBD or chronic lung disease, finger clubbing, think about immunodeficiency, cystic fibrosis, BCD, failing to thrive, cystic fibrosis, especially when there is chronic diarrhea and others. So you need to refer when the patient diagnosis is not clear. Okay, when there is vomiting, persistent vomiting, when there is persistent wheeze, when there is persistent wheat cough, when there is high parent anxiety, failing to thrive, clubbing, stridor. Step 3, younger age group. Step 4, older age group. Okay, or frequent exacerbation. Take home message that asthma mimicker is common. Uncontrolled asthma, you should think about asthma mimicker. You should think about alternative diagnosis in younger age group. Okay, detailed history is crucial. Detailed examination is very important. Okay, asthma predictive index can be helpful. Focused investigation, okay, needed, and expert opinion. And this is my last question for this presentation, and I will be happy to have any comment and any questions. Shukran, Dr. Nabil.
Thank you so much, Dr. Abdullah, for your very excellent presentation. I have just a question for you. It can be also related to the same, but we have in the last 3 to 4 months, we got newborns, sick newborns transferred from peripheral hospitals. There is a specific family, I will share it with you after this, maybe. They came with repeated chest infection, and they are stuck to the ventilators. Then we treated in the first as pneumonia. Babies are improving, then soon they will deteriorate again. And then we suspected immune deficiency. And we done the screening only, and it came to be positive combined immune deficiency.
Okay.
So my question, for this age, do you consider this directly as combined immune deficiency, or you will repeat the screening once more, or you will widen? Before we will have, as you know, we will have Dr. Zena. She is a consultant immunology, and she was doing a lot of investigations until she will confirm the diagnosis, but now she is not with us. In this case, should I refer the baby direct to a center with bone marrow transplantation, or I have to wait and see again if someone can re-evaluate him and diagnose him really, as I'm afraid that it may be due to infection or due to severe bone marrow depression or something like this?
Shukran, Dr. Nabil. Thank you so much. This is a great question, really. Okay. We are commonly seeing unusual cases in the nursery. Okay. And in here, I would say the family tribe, al-ailat or al-qabila, make a big difference for us. Okay. For example, I'm Shamrani. Shamrani, they have sickle cell disease and G6PD. But for example, Al-Unazi tribe, they have cystic fibrosis because the gene comes from the north part of the kingdom.
They are Sha'rawi.
The SCID and Bessel lymphocyte is usually in the family of Al-Utaybi, okay? So that doesn't mean that Al-Utaybi, but they are prone, okay? So the family tribe make a big involvement, okay? And in general, the message, any invasive infection, neonate or non-neonate, deserve to check the immune status of the child. So if your patient now is diagnosed to have the SCID or Bessel lymphocyte, it automatic refer to Kingfisher for bone marrow transplant, okay? So I would say now we are having low threshold for the gene study. Now, not like before, going, for example, immunoglobulin and T cell subset direct. Okay, so there is a big change nowadays to go for the gene study, and the gene study 3,600 or so, and it will give you the final diagnosis. So your patient, I feel it's as soon as you refer the case as better for the outcome and long term for your patient. So this is very bad, unfortunately. Otherwise, you will wait another event, maybe ventilated, maybe death. So this is take care, send as soon as.
The problem that, you know, when you will speak with an MOH hospital and you are asking for a bed in the NICU with ventilator, it's very difficult to get the bed.
Wallahi, I know, Doctor. I know it's everywhere now. There is a restriction about the gene, and if patient labeled or suspected to have gene problems, you will be out from the insurance, and this will be a big burden financially on the family, as you know that the cost for each night in the NICU or BICU is so much. But definitely we have a lot of surfactant deficiency, interstitial lung disease, immunodeficiency, chronic lung disease, neurological problems, metabolic problems. So these are really a burden to everyone, especially colleagues in nursery, and it is financially consuming. But just imagine one night maybe in the NICU, it deserves the cost for the gene study. I will push for the gene study by all means if I convince the family to do it on their expense.
We got now an agreement with some labs. They are doing it for 2,000 only.
Allah Jazakallah khair. This is great news for the country in general.
Yes.
I hope there will be a system to protect such kids in the NICU, really.
Inshallah. Anyone has a question? Until now, I don't have. So if like this, okay, we will move to our second presentation. Still will be with Dr. Abdullah. He will speak to us about obstructive sleep apnea. So you are welcome to Abdullah.
Just give me a second till I prepare myself, please, for the second talk.
Take your time. No problem.
Is it sharing now?
No, not yet.
Not yet?
Not yet.
Wait, 1 second, please.
حضرتك افتح البرزنتيشن الاول يا دكتور عبد الله وبعدين اعمل له شير، لان هو مش هيشير لما تفتحه دايركت من هناك.
اوكي. طيب now.
افتح على ميلك خالص وبعدين بعد ما يفتح يعمل شيرنج.
Yes, I get it. Is it sharing now?
Yes. Make a full picture and this. Yes.
طيب السلام عليكم ورحمة الله. So this is the second talk about obstructive sleep apnea in children. Obstructive sleep apnea, I would say, gaining more popular nowadays as sleep is an area of improvement for the last 2 decades. Maybe 2 decades ago, the sleep position were counted in the tip of one hand, okay, tip of fingers of one hand. But now, alhamdulillah, we are exceeding maybe 30 sleep position in the country. So in looking to the literatures, okay, the sleep in the past being missed. Okay, so this is the overview, and here some introduction, okay, some review of OSAs and modalities, how to diagnose, how to treat such patient, and certain messages at the end. Okay, so the objective in here is to recognize signs and symptoms of OSA and to update audience about the latest guidelines for managing obstructive sleep apnea. I think this is really very important article. I spent maybe 2 months, okay, revising literatures and writing this clinical approach for diagnosing childhood sleep disorder of breathing. Okay, so the title is sleep disorder of breathing, and my title in here is obstructive sleep apnea, and you will see later what is the differences between these two. Okay, so in the past, so nothing in literature before 1950s. In the past, the OSAs been diagnosed by cardiologist as heart failure. OSA still patient present with heart failure, or by endocrinologist till the patient has severe failure to thrive. And sometimes reported literature here and there, sudden death, especially with anesthesia, like spinal bifida with myelomeningocele and others. And since 90s, now we started to see OSA, upper airway resistance syndrome, hypoventilation. And for the last 2 decades, now we have 2 types of OSAs. Okay, type 1 and type 2. And we will see later what do we mean by type 1 OSA and type 2 OSA. So now there is a spectrum, okay, for sleep disorder of breathing. The worst is the OSA. So I like in general people not to miss the OSAs. But I like the people as well to know what do we mean by the BS, primary snoring or simple snoring. And in between, okay, what do we mean by the upper airway resistance syndrome or hypoventilation? So these 2 extremes, in the past we used to say primary snoring or habitual snoring. This patient, he used to snore. So this is not true anymore. Okay, snoring is pathological. Okay, and there is a risk of hypertension and other complication on long term. Okay, whether you accept it or not, this is literatures. But we should label snoring if no sleep disturbance, no hypoxia, no hypercarbia, in order to say this is BS. Okay, despite the BS, primary or simple snoring, there is risk, as I mentioned, even school in kids, cardiac, metabolic. So how about the extreme, the other extreme on the right side, or say obstructive event? So there is hypoxia, there is hypercarbia, and there is abnormal sleep pattern. Okay, and this the thing that disturb the life of the kids and the family. Okay, so I will give you a certain scenario. This is a common type 1 OSA, which is type 1 adenotonsillar hypertrophy. Type 2 obese related like the other. So this patient, she is 2.5 years in winter time. She had adenoidectomy and she has upper respiratory tract infection. I have her video at one time. Okay, so she had really, as you see, she has pectus excavatum. Why pectus excavatum? Because of long-standing upper airway obstruction, and she had tracheal tug, and she ended in the ICU. Why? Because there is a chance of recurrence of adenoid in younger age group, and this patient has tonsillar enlargement. Okay, as you see in her BCO2 is high, and there is a cardiac strain as well. Okay, so now even now this patient, lucky that she was treated partially with adenoidectomy, but adenoidectomy at one time is not enough for treating OSA. The standard is adenotonsillectomy. Okay, so there is still delay in diagnosing and treating OSA. Like this patient, second case, I have seen this case. Patient, if you see the X-ray on the left side, oh, big heart and congested lung, heart failure. I'm reassuring you, there is no single septal defect in this patient. So why is having OSA? Why is having heart failure? OSA. Okay, so this is a Down syndrome. OSA, okay, can cause heart failure. Okay, I know it is low nowadays. Less than 10% of the cases of OSA will present with heart failure, but it can cause. It can cause, like OSA can cause in nursery, the hypoxia, meconium, severe anoxia, hypoxia, Sarnati scale. It's the same here. OSA can cause cardiac strain, liver enzyme increase, renal enzyme. It's the same in general, but this is long-standing and this is unacute, okay? So again, this patient, we have done adenotonsillectomy, and 2 years later, this patient came to me with mouth breather. Oh, again, he had adenotonsillectomy. So still there is the message in here is still residual OSA in Down syndrome. And they will show you what is the residual OSAs in certain high-risk group. This patient, he has Prader-Willi, okay? At one time, he's in ICU, failed extubation many times. I have done many time consultation for colleagues in ENT to do adenotonsillectomy. They said, no rule for adenotonsillectomy for this patient. I have done cardiac assessment for this patient numbers of times, okay? There is no echo evidence. So we challenge and we contact the adult because we're big with child. So when they brought the probe from the adult, the patient has suprasystemic pulmonary hypertension, okay? And when we start the antihypertensive pulmonary hypertensive medication, and we went for sleep, this patient, you will see this picture, patient who died, almost about to die, his picture later on. Okay, and this is another case. You might see it sometime prematurity, okay, sometime either laryngomalacia due to reflux disease, or sometime due to subglottic stenosis due to long-standing or difficult intubation. So these now just appetizer for us, OSA, okay? So these patients present with stridor breathing, okay? So as I told you, any lesion above the thoracic inlet will give you stridor. Stridor or snoring, doctor? Snoring limited for sleep status, stridor on awake condition. Usually stridor, we like it at laryngeal level, okay? While snoring, usually at hypopharynx level, adenoid and tonsillar level. So OSA is a disorder of breathing characterized by prolonged partial upper airway obstruction or intermittent complete obstruction that disturb normal ventilation, disturb sleep, and definitely affect all age group, okay? The change and the obstruction in the airway is little, often during sleep, often during REM, silent can be missed. Most majority the kids, the family are sleeping, and usually most of the infant in the last third of the night during the REM stage, and the family, most of them are awake. During awake condition, majority of the kids, they are normal. So you might see hyperactivity, and I will show you a certain message for the to observe during the time. Okay, so it is OSA about up to 4%, just the peak 2 to 5 years, more in black. Simply, you can say 1/3 of asthma. Oh, but asthma here in the kingdom is high. But I would say snoring here in the kingdom is snoring. I have hopefully just accepted in Saudi Medical Journal prevalence of sleep disorder of breathing, okay, and the prevalence of snoring is around 17% in the kingdom, okay. So similar to Bahammam, his old report 2006. The Down syndrome, they have the typical picture of all parameter for the OSA, whether upper airway narrowing, hypoplasia of the maxillary bone, hypotonia due to the innervation, and combination factors. Okay, so majority of the Down syndrome, and Africa 80% they have OSA. In literature, you might see down to 35, but could you see up to 100% of the Down they have OSAs? Okay, so the factor that affect breathing, is it awake, for example? Patient has flu illness, patient in sleep status, okay, patient in REM, any brain problem. So when the patient is going to sleep, okay, there is loss of neuromuscular tone, okay, or coordination. The airway will get collapsed. The child will start to have desaturation until he get apneic, okay, hypoxia, hypercarbia. Then now he will start compensating and arousability and will awake, and the tone will increase and try to compensate and hyperventilate, and the child will not able to sleep. Just imagine these events sometimes happen numerous times, exceeding 30 events in 1 hour. Okay, exceeding 30 events in 1 hour. So apnea, hypoapnea index, sometimes we are saying the severe is more than 10. Okay, sometimes I have seen it exceeding 50, 60, 80 per hour. So you should know what could be the night symptom of OSA. So loud snoring, more than 3 nights a week is significant. Witnessed apnea, restlessness during sleep, abnormal sleep position, sleeping with extended neck, for example, enuresis. Enuresis is very crucial. Sometimes kids have primary enuresis, 5% at 10 years of age, 10% at 5 years. Oh, but if patient has loud snoring and has enuresis, this patient has active OSA, like double-stranded DNA in SLE. Okay, so this patient needs an urgent intervention. During daytime, the child might be starting with morning headache, mood problems, fighting with family and colleagues, okay, nasal congestion, mouth breather, or behavioral problems, hyperactivity, low attention, hyponasal speech, dysphagia, school performance, poor school performance. And this is being proved by Dr. David Gozar that for example, grade 1, the lowest 10% academic performance have 6 times OSAs than regular patient. Okay, so sometimes they are labeling the OSA is disease of stupidity. Okay, so if one is snoring with the enuresis, I'm not expecting that this candidate could fight, okay, for be the first rank one in the class, okay, because the brain is not able to sleep well, is always busy with correcting the hypoxia and hypercarbia all the time, and is not refreshed in order to get better memory and full attention next day. So physical examination, majority of the OSA during awake time is normal, okay, but you might see underweight, you might see overweight, you might see some craniofacial malformation, any crozone or the craniosynostosis. This is by default OSA cases, okay, Down syndrome, okay. Oropharyngeal examination is very important. For example, adenotonsil hypertrophy, allergic nose, whether 2 type, runny nose or black nose, okay, purulent nasal discharge, okay, so sinus infection. So the child will present expected to have sleep problems. Pectus excavatum. Pectus excavatum, okay, this is a reflecting long-standing upper airway obstruction in the infancy period. And sometimes even you might see cardiac strain, loud B2 in the cardiac area. And you should know the risk group. And I will give you a slide. What do I mean by the risk group? This is really very important later slide. What to do for certain risk group. You'll send them automatic for adenotonsillectomy or with observation and other precaution. So remember that the only history, what I mentioned, it could be just predictive in 30%. So, you might need high index of suspicion. So you might need physical examination, might not be enough to predict the OSA because this is a condition limited to sleep status, okay? But sometimes, this is yesterday, I have seen a child, an Indian child with loud snoring, and the tonsil was normal, okay? But when I have done the underweight, by the way, and the child has very loud snoring, so this is large adenoid, okay? So what shall I do for this large adenoid? Automatic, shall I send them for ENT? I give a trial of 6 weeks of medication, then we will be reassessed. So this is again large adenoid, okay? So X-ray it might be helpful, big heart, because cardiac strain, or sometimes cardiac strain, especially right atrium. CBC, why CBC? Sometimes hypoxia, it will cause stimulation of erythropoietin, and you might see polycythemia or increased hemoglobin, blood gas. In such cases, I will go direct. What is the bicar? Is bicar more than 26? Usually bicar 23 plus or minus 3, unless exception maybe in neonatal or accept lower. Okay, so any blood gas, for example, bicar more than 26, there is metabolic alkalosis. So metabolic alkalosis, I'm expecting respiratory acidosis. So nasoscopy can be helpful and laryngoscopy. So the only And the best diagnostic study for sleep for OSA is BSJ. But if you put the BSJ in the Google, you will see Messi and Neymar. Okay, so BSJ is polysomnography. Okay, so this is the golden standard diagnostic test for OSA, and this is just 1,000 evoke sometime, 1,000 evoke. Okay, for one night sleep. Okay, and will take maybe 3-4 hours from the sleep technician and the sleep physician to do interpretation, to come again later on with the apnea hypopnea index and the oxygenation and the ventilation and others. So this is the normal parameter of the BSG. Okay, so the at least should be at least the study 6 hours, and the sleep efficiency is supposed to be should be more than 85. Okay, and the sleep stage, there are two types of sleep stage, either non-REM N1, which is the فترة النعاس, into this is light sleep. When we awake, will be easy to be awake, but the N3, when you be awake, you are disoriented, you don't know where you are. And the REM should be at least usually around 20%, and could be higher than this in the neonate and the premature people. So this is the most important parameter. Apnea hypopnea index should be below 1.5. Okay, so up to 5 mild OSA, more than 5 to 10 moderate, more than 10 is severe OSA. So when I should refer the child and do the sleep study, the polysomnography, if I want to differentiate, is this patient BS or OSA? If the patient has unexplained daytime sleepiness, which is common in the adult rather than the pediatric, okay? If I want to titrate the patient with the CPAP because it's severe OSA and the ENT schedule, sometime I refer for ENT and appointment after a year, okay? And if I have this sleep study, okay, that this patient has severe OSA, I need to start him with a CPAP and nasal medication till I have to be seen by the colleagues from the ENT, okay? So pre-operative for high-risk group. And again, I will show you another slide for the high-risk group. So I need to do the sleep study, I would say 3 months, minimum 6 weeks after the sleep study to confirm the improvement. Sometimes if patients, for example, have 80% apnea hypopnea index, for example, Prader-Willi or severe OSA, as we know that we have seen sometime body mass index exceeding 55 in simple obesity nowadays. If patient has hypoventilation, if sometimes sleep study can be helpful, for example, pre-decannulation, or if there is concern about ROHAD or congenital central hypoventilation. Okay, so now these are I would like to know, just to remember that BS normal simple snoring, normal BCO2, normal saturation. The OSA, just remember the apnea hypopnea index. Okay, 5 below 5, 5 to 10, more than 10. And if you go for the entitled, the BCO2, you can say 10%, 10 millimeter, 45, 55, 65. Even majority, more than 6 is severe hypoventilation. Okay. Now, if you don't have the sleep study, still I could finish in 2 minutes time, Dr. Nabil. Sleep study, overnight pulse oximeter. Do overnight pulse oximeter. If you are positive with desaturation, as you see in here, and clustering of desaturation, this patient has OSA. But if negative, you cannot roll OSA. If you proceed for a sleep study, still you might be able to pick up 40% of patient to have OSA. No rule for NAP, no rule for audio, video, okay? And in general, I told you the children, the main cause is adenotonsillar hypertrophy, obesity in the adult. The index is 1 or 1.5, 5 in adult. Now, there is the emerging problems in kids nowadays, obesity exceeding 50% adolescents. So now there is what? Type 2 OSA behaving as adult-like. So their presentation like metabolic syndrome, obesity, dyslipidemia, hypertension, and acanthosis and insulin resistance. Okay, while the adenotonsillar hypertrophy-like, they are thin, they present with hyperactivity and low attention. Okay. So these conditions, you should remember it all the time: craniofacial, neurological, abnormal muscle tone, and reduced upper airway, like obesity and the others. Okay, so Untreated OSA, they have major. I usually present, this is a separate talk. Cardiovascular, from pulmonary hypertension till systemic hypertension. It can cause. I have even publication that OSA can cause systemic hypertension. Okay, it's proved to cause pulmonary hypertension. There is physical sequences. There is metabolic sequences. There is emotional. There is cognitive. There is social, health, major health problems, growth impairment, enuresis. So there is many concern. Medical treatment. There are 3 types of medical therapy. Okay, medical, surgical, or mechanical. Okay, according to the severity. And this the severity. If you are having the sleep, if you have the sleep index is PSG, mild, moderate, severe. Okay, so mild cases you can go with medical therapy like Nasonex and the singular Mentolocast. If severe, direct for the adenotonsillectomy. This is very important slide. Okay, please remember it. The age less than 3 years, severe OSAs associated with medical condition. Okay, or comorbidities. And the mild OSAs treated with nasal steroid, leukotriene, sometimes trial of steroid, the surgical adenotonsillectomy rather than the adenoidectomy, and sometimes sleep, sometimes trach, and there is residual OSAs. Very important now, as I told you, obesity 55, for example, Down syndrome 30%, and there is a role now for the CBAB and BiPAP, and the whole message that it is a common sleep problems. Current modality is still underestimating the OSAs. You need an expert. Okay, and I'm really sorry that I didn't utilize the time very well. Shukran, Dr. Nabil, I'm sorry for the time. Huh? Shukran.
No problem at all, Abdullah. You have an excellent presentation, and it was amazing. I just have one question from my side and one from the audience. From the audience, I will start with seasonal asthma needs same protocol for prophylaxis.
If you label your asthma, you need to treat for 3 months, okay, and reevaluate minimum, okay, and you need to grade it either step 1, step 2, according younger age group or older age group. Less than 4 years, okay, go for Fluoxetide 52 puffs BD. If it's step 2, step 3, Mentolocast singular granules. Step 4, older age group, Fluoxetide 125. In first step number 1, episodic Fluoxetide plus Ventolin. Step 2, regular Fluoxetide 125 1 puff BD. Okay, then step 2, adding doubling the dose or change to Seretide. Usually we are preferring Seretide in the older age group. Treat for 3 months, then reevaluate.
Thank you so much. Then my question is about night sweating in children. I did not.
Yes, it is a presentation. If patient has very difficulty breathing, snoring, sweating, it is a sign of. It's not one of the night symptoms suggesting OSAs.
Especially at night.
Yes, please. Yes, please.
Okay, thank you so much.
شكرا.
Is there someone? Oh, لا, خلاص. Okay, thank you so much.
الله
شكرا.
يحفظك. شكرا لكم. حفظكم الله.
Excellent presentation as usual. Thank you. You can stop sharing your stuff.
خلاص. I have done it.
شكرا. So our next speaker will be Dr. Mohammed Al-Ghamdi. Dr. Mohammed Al-Ghamdi is a consultant pediatric cardiology in National Guard Hospital and in King Khalid University Hospital. He is a professor in King Saud University. Dr. Mohammed will give us 2 talks. The first one will be about the management strategies of BDA in premature babies. The second one will be approach to acute chest pain in children. Welcome, Dr. Mohammed. If you are ready, you can start to share your screen.
السلام عليكم. مساء النور جميعا.
مساء الفل يا سيدي وكل سنة وانتم طيبين و Foundation Day.
يلا الله يحفظكم. أنا بس I will try to share my slides. Do you see it now?
Yes. بس انت جايب من الاخر على طول سانكس.
لا خلاص رجعنا خلينا نرفع
يلا اعمل بس فول سكرين وتوكل على الله. اوكي ناو.
So you see it now.
Yes. Very good.
الصوت واضح؟
واضح.
السلام عليكم ورحمة الله وبركاته. Good evening everybody. So I'm gonna speak today about PDA, and my main focus is the PDA in a premature baby. And the next lecture will talk about the chest pain in general. So as you know, in fetal circulation, ductus arteriosus, we don't call it PDA. PDA, patent, mean postnatal. So in fetal life, we call it ductus arteriosus. And it's actually a connection between the aorta and the pulmonary artery. And the main job of the ductus arteriosus is to divert blood from the lung to the placenta, because placenta is the organ that doing the lung job. And beside the foramen ovale, ductus arteriosus is essential for life. And without it, the baby die. And actually, we had many baby that we have to deliver near term, because the ductus arteriosus start to get smaller, especially in mother who are taking non-steroidal at the end of the pregnancy. So it is a very important element of fetal circulation. Why it's still open? For many reasons. One of it is hypoxia, because as you know, the fetal circulation has low hemoglobin concentration. But more importantly, because of the production of prostaglandin from the placenta. So the placenta produce a lot of prostaglandin that keep the ductus arteriosus. So after birth, the baby cry, the lung open up, and the amount of oxygen content in the blood increase. So that's actually one of the reasons why the ductus start to get constricted. But more importantly, the prostaglandin was eliminated because the placenta is eliminated as well. And then probably the prostaglandin will reach a very minimal level after 3 hours of postnatal life. And then the baby, the ductus will get smaller and then close. In premature baby, the constriction is not abundant. Why? Because the oxygen, because the PDA are very thin wall, and the oxygen by simple diffusion can reach to the muscular level of the PDA. So it will not constrict as you expect in the term baby. And that's why it is a major problem in a premature baby, especially those who are extremely premature. دكتور نبيل الصوت واضح؟ دكتور نبيل.
Yes.
اي تمام يلا اوكي. طيب so what is the issue with the ductus arteriosus in premature baby? And actually in term and premature, but mainly in the premature baby. The presence of ductus arteriosus will change. It is unnecessarily present in postnatal circulation because lung is working, and we don't need to have any mixing between a blue blood in a pulmonary circulation and red blood in the systemic circulation. Because of the drop of pulmonary vascular resistance, which happened earlier in premature baby, especially those who receive the PLES, the surfactant, the flow in the ductus arteriosus change from right to left in fetal circulation to left to right in postnatal. And because of that, that will cause pulmonary over shunting, and that will lead to pulmonary complication, including congestion, difficulty to wean from a ventilator, and even pulmonary hemorrhage. That blood, which shunt left to right, is stealed from the systemic circulation. Then we will have hypotension, white pulse pressure, and the systemic organ will suffer from hypoperfusion, which can lead to all the complication. We will talk about it in the next slides. Besides that, the left ventricle become more dilated, and with more dilatation, that will cause dysfunction as well. So that will add more to the pulmonary congestion, and that will add more to the systemic hypoperfusion. If you look at the premature baby, especially those who are extremely premature, and I'm talking about those in the 700, 600 grammer and below, as I say, the pulmonary overshunting will cause pulmonary edema and systemic hemorrhage, and the systemic hypoperfusion to the vital organs are responsible for many complications, including intraventricular hemorrhage, brain ischemia and white matter changes. Necrotizing enterocolitis definitely is a complication of PDA if it is hemosignificant, as well as the renal impairment, because the total systemic circulation to the kidney is up to 30%. So if the blood steals from there, the kidney is one of the organs will suffer early. So how would you diagnose PDA? It's actually clinical, and the gold standard test for that is echo. Sometimes it's not straightforward to diagnose PDA in a premature baby, so you need high index of suspicion. And there is many things that make you think your baby, especially after the first, maybe second or third day, is now having a hemodynamically significant PDA. If you start to see reduction in lung compliance in a ventilator setting, or the ventilatory support become worsening and you have to increase the pressure. If you do an X-ray and you find the lung is more congested, if you find it's difficult to wean from mechanical ventilation after improvement, let's say you give surfactant, the patient improve, and after like 1 or 2 days, things getting worse. If you start to see blood pressure dropping, hypotension, you have to give dopamine and some inotropic support. If you start to notice the urine output is low, or any sign of NIC or unexplained metabolic acidosis, all those are clinical feature of hemodynamically significant PDA. How would you confirm that? You need to do an echo. So the echo is how you find it. I explain most of the clinical signs and symptoms, but I'm just going to mention a few things here. The white pulse pressure, it's not sensitive to detect PDA. We see a lot of hemodynamically significant PDA without white pulse pressure. You're not going to hear the continuous murmur that we hear in PDA in older kids, but you might start to hear loud systolic murmur. You might feel the heart is active, but feeling active heart in someone is ventilated is not easy as you think. So once you suspect PDA, or if you are in a unit that do screening for PDA in day 2 or 3, you have to know the echo is the gold standard for diagnosis of PDA. And echo, as you know, it is operator dependent, so it depends on the person who's doing it, but it will confirm the presence of significant PDA. There's criteria we'll show you. So once we diagnose a PDA, we'll classify it as hemodynamically significant HS PDA or non-hemodynamically significant PDA. And then it's not only that, but also we have to assess cardiac function, but also equally important, you have to rule out cardiac anomalies that are duct dependent. For example, if you have coarctation, a large PDA, the PDA should not close. It should stay open, and you might actually need to start patient on prostaglandin rather than non-steroidal or other treatment of PDA that are responsible to close it. So I already described the clinical factor of hemodynamic significant PDA. Just going to go through it quickly. If you start to see the patient requiring more inotropes, ventilatory support becoming worse, you start to notice pulmonary edema or hemorrhage. The baby start to have feeding intolerance, or the urea and creatinine is getting higher for no good explanation. You have also to categorize your baby to high risk, moderate, and low according to the weight and gestational age. So definitely less than 25 weeks is high risk for significant PDA. More than 28 weeks is a lower risk, and in between is a moderate risk. So there's a lot of confusion about how you diagnose significant PDA by echo. And I think it's just many of that to do with sticking to a certain number. It is not true. You cannot just diagnose significant PDA based on measurement or diameter or left atrium to the aorta size or just dilated left ventricle. That is what written in many of the neonatal book, and it's many times it's not true. You have to look at other criteria, and I will explain it. I will spend more time in here. One, PDA measurement by 2D is difficult, and doing echo in a small baby with this very narrow ribs also make the quality of echo is not the greatest. So you cannot just depend on the measurement alone to decide it's significant or not. We always say PDA more than 2 millimeter is significant, but you might find lesser than that and it's significant. So it's not just a number. And the other problem here, where you measure the PDA, you measure it in the aortic end or pulmonary end. You measure it using 2D or using color. So I'm not going to tell you how I do it, because maybe in my hand is accurate, but for another hand, maybe not. I depend more on color, but I have to adjust color very rational and to reasonable thing. And I measure with that, because many times I find 2D is not as accurate in the measurement, but that's my personal preference. In books will say, don't measure PDA using color, but also it depends on the experience hand. Second thing, you have to look at the shunt pattern, and this is very important. This is very important. The shunt pattern in a PDA will tell you if the PDA has criteria of significant shunt or not. And I will show you some example of that. So if you start to see small PDA, the pattern of shunt become restrictive, continuous, systole and diastole. If you see bidirectional, yes, maybe PDA after a few days will be significant, but at that moment of bidirectional shunt, it is not hemodynamic significant because pulmonary vascular resistance is still high. Usually the hemodynamically significant PDA showed pulsatile flow, and I will show you how it looked like. Second, look at the degree of pulmonary overshunting. The common number that used in many echo book and neonatal book is looking at the left atrium and aorta ratio. If it is more than 1.4, they will call it significant, and if it is less, they will call it not. This is not true, because of many reasons. Number one, so actually what that tell you that the left atrium is dilated, but let's say this patient has significant ASD. Significant ASD will make left atrium not dilate. Actually, left ventricle will not dilate. The right side will dilate. In that case, it's not the left side who's going to be dilated. Second, you might have a small PDA, but significant mitral valve regurgitation. So the left atrium will dilate because of the MR, not because of the PDA. So more importantly, to look at size of the PDA. If you find the PDA are pulsatile flow, if you find continuous flow in pulmonary artery, that is significant. Pulmonary artery should not have continuous flow. It should be only during systole. But if I find RPA, which is far from PDA, showing continuous flow, that's mean PDA is significant. You have to look at the pulmonary venous return. If the pulmonary venous return is increased, pulmonary vein is dilated, that's significant PDA. So it is not only left atrium enlargement and left ventricular enlargement and the PDA size, it is other things you have to look for. Second thing, descending aorta, if you start to see a reversal flow, that's significant PDA. But in many significant PDA, you might not actually see that yet. I don't use organ blood flow as a way to measure. I don't think it's accurate. It's written in the book. I don't use it. Like the Doppler, the middle cerebral artery, the superior mesenteric artery, and other things. If they find less antegrade flow or absent of diastolic flow, that would cause significant. By the way, if you find this, it's actually more easy to find retrograde flow in the descending aorta without going to those small vessels to assess. That is what I'm talking about. That is a PDA. I'm here. This is my cursor in the PDA. You can see the left to right shunt, but look at the flow pattern. It is pulsatile flow. It is not continuous. So it is like an artery. That's a systole, then disappear almost in diastole, or it is very flow and very little flow in the diastole. That is a hemodynamically significant PDA. Again, I didn't have the slide. I don't know what happened, but continuous flow in the PA branches is indicative of significant PDA. And also, if you see dilated left heart chamber is significant PDA, but you have to remember, presence of ASD make left side not dilate. Actually, the right side will dilate, not the left side, but still significant PDA. That is the PDA restrictive flow pattern. You see now, this is systole, diastole, continuous. That is probably not significant PDA, but also you have to look for other criteria. Look at the difference between this restrictive pattern. I'm going to go one slide back, and that's a pulsatile flow. That is the pulsatile flow is going with significant PDA. The restrictive pattern, maybe it is not significant, but you have to look for other criteria. If you see PDA bidirectional, that's a PDA here flow. This actually big one is the left pulmonary, the aorta. The PDA, there's a double envelope here. That is a right to left shunt during systole. This is left to right during diastole. That is PDA. Maybe it is large, huge, but shunt-wise, it is not significant to cause pulmonary hypertension, pulmonary overcongestion, because pulmonary resistance is still high. In this case, you have to repeat the echo after 1 or 2 days to judge if the PDA flow changed. So once you diagnose a PDA is significant, then it depends on your lab. Personally, I'm aggressive with PDA. I think PDA is a killer in an extremely premature baby. I don't think like leaving PDA is doing any favor for the premature baby. I think a lot of complication, that's my belief. I think a lot of complication that was, we thought it's related to the non-steroidal is probably PDA complication rather than non-steroidal complication. I'm not denying it could be non-steroidal, but I think NIC that happened is PDA related, maybe not ibuprofen related. Maybe the IVH happened was PDA related because we left it longer, not non-steroidal related, and etc. So I'm not going to go through the algorithm because this is the algorithm we use in National Guard. But screening PDA, some institution will do screening, some will go for clinical. But if you're going clinical, you have to have high index of suspicion for diagnosing PDA. If you have a screening in 48 and 72 hours, probably you're going to pick up more significant PDA. You're going to treat more PDA earlier than if you just follow the clinical sense. Once you diagnose PDA, then you have to classify it as hemodynamically significant or non-significant. And if it's significant, then you have to treat either with non-steroidal, paracetamol, and if it doesn't work after 1 or 2 weeks, then you have to go for surgical ligation. I'm not going to go through the treatment because every lab, it's actually, you can read about it, but I'm going to go through a few things. Personally, I'm not a good believer in acetaminophen as a good treatment for PDA, but sometimes you have to use it in someone who has low platelet and pulmonary hemorrhage. Anyway, if you use it, you have to do serial follow-up echo for that patient, and then you have to stop it once the PDA becomes smaller or hemosignificant. One of my observations that it actually PDA might get smaller. I don't know if it's acetaminophen related or other measures that you did with the fluid restriction. I don't know. But once you diagnose it, then you have to stop and watch and monitor. You have to monitor for liver failure because, as you know, systemic can cause hepatotoxicity. And ibuprofen can be given IV, oral, indomethacin only given IV. This is the complication, significant renal impairment, neck, intestinal perforation, thrombocytopenia. I think maybe some of those complications are PDA related, not medication related. I'm not ignoring the fact that might cause it, but if you use non-steroidal, definitely you have to watch for the urine output and you have to monitor the patient. When you go for surgical, if PDA remains hemodynamically significant and patient is like not candidate for medical therapy, you need to do surgical ligation. If you have PDA that treated medically but not responded, and especially if you pass the first 2 to 3 weeks, then you have to go for surgical ligation. So surgical ligation usually done from left thoracotomy because the PDA in those baby are very fragile. You didn't need to cut it; you just clip it with the metal. But it's very easy to rupture actually if you are very aggressive with closure of PDA. And you have to remember that surgical PDA ligation is not free of a complication like vocal cord paralysis, diaphragm paralysis because left laryngeal nerve. But very important to remember one fact. Once you close the PDA, patient might suffer in the first night from what we call post-operative hypotension. And this is to do with a sudden loss of preload due to Starling law, but also a sudden increase in the afterload, what we call afterload mismatch. I can speak 1 hour about that. That might be related to hypotension in the first night after PDA ligation. And the treatment for that, usually you have to give the patient enterobic support and some fluid challenge. In conclusion, hemodynamic significant PDA has a deleterious effect in premature baby, especially those who are extremely premature, mainly due to pulmonary overshunting and systemic hypoperfusion. Once you suspect it clinically, you have to have high index of suspicion. ECHO is the gold standard test to prove it. And there is no one ECHO parameter is enough to judge PDA either significant or not significant. It depends on the expertise of the cardiologist. Medical management of PDA should not be delayed, and surgical are an option if medical management failed or the patient passed the period when medical treatment can do the job. And thank you so much for the first lecture.
Thank you so much, Dr. Muhammad, for your excellent presentation. I just have a question for myself. You know that in our unit, we were taking the first priority for indomethacin. But now when we started to revise and discuss with others, and even in our hospital, knowing that the indomethacin is not registered by the Saudi FDA, we have to change. So do you recommend to continue with our protocol or to shift as what you showed us now to acetaminophen? In spite, I'm sure that it is not as effective as indomethacin, and we did not get too much complications with our indomethacin regime. But even as you know, we got many cases referred to us for surgical ligation after failure of ibuprofen and paracetamol in other hospitals, and we just give one course of our indomethacin, which we are bringing from Egypt actually, and it closed without surgery. So what's your comment?
And honestly, the amount of PDA closure of medical treatment, I have not seen a better response than indomethacin, especially the one from Egypt. I don't know. That's my experience. In other hospital I work with, for example, in other private hospital use ibuprofen. It's effective, but the indomethacin for me is actually a very good job. Do a very good job. Again, I'm biased. I am biased. I'm just telling everyone I am biased, but I'm not as a paracetamol believer. I think it make it smaller. I went through all the literature around it. It's not making sense to me. Maybe I will change at one day, but I'm not a believer in paracetamol. National Guard use paracetamol as therapy, and they see good response for that. I don't know if it's paracetamol or actually the time that make it smaller, but definitely many of patients who are paracetamol, once you finish the course, they just get bigger again. So again, everyone probably will have a different opinion than me. I have discussed it with many experts in the field in ICU. I usually leave it for them to decide. For me, I just tell them it is significant PDA, and then use your protocol. And I'm available to repeat the echo to see if your protocol is working or not. I usually don't intervene with the type of medication they use.
Actually, I myself was in Germany from 2004 to 2006, and I participated in a study comparing indomethacin and ibuprofen for PDA in both extreme preterms and preterms, and we end up with the conclusion that indomethacin is superior to ibuprofen, and there was a rate of reopening after closure with ibuprofen, oral ibuprofen, more than indomethacin. But
Yeah.
as you told, the literature is saying go to this, but I don't know. Still, I'm believing in indomethacin more than others.
Dr. Nabil, the PDA literature from NICU is very confusing.
Yes.
In terms of like treat, not to treat. For me, PDA in extreme premature baby is a killer and need to be managed. Like physiology said that. What you choose, it depends on your institution. I don't think it's true to leave PDA that's significant, and then you blame PD treatment later on for IVH, you blame it for the bronchopulmonary dysplasia. It is not the indomethacin. It is a complication of prematurity and other things, not because you give 1 or 2 course of indomethacin.
Okay, thank you, Mohammed. Any question? So we'll move to our next presentation with Dr. Mohammed. You will start with approach to a child with chest pain. تفضل Dr. Mohammed.
Okay, let me share my slides.
Okay.
You see my slide now? Is my slide clear?
Yes. You can just make full screen and start. Yes, now it's okay.
Okay, so again, good evening, everyone. My other lecture is probably like less heavy duty than the PDA in premature baby with all controversy. It's about chest pain in children, and I never have any clinic in the last maybe 13 years in my once I'm consultant. I never have any clinic without a child with the chest pain. So it's actually very common. And if you look at the literature, it is the second most cause of referral to pediatric cardiologists after heart murmur. So it is a very common thing. And if you work in ER, probably you will have a lot of patients coming with the chest pain. it is not, you think it's a simple thing, but an anxiety of a chest pain that create for the family, it's huge, because they usually think chest pain is cardiac related, as it is usually the case in adult patient. So let's start with this scenario. You have an 8-year-old child came complaining of a chest pain that was described as central in location. Physical examination was unremarkable. So what I'm trying to cover here is what is the important thing in history taking, what is the important thing in physical examination, and what is your differential diagnosis, and how would you manage that child. So again, I already said that chest pain is a very common symptoms, either to the ER or OPD visit for a pediatrician and for pediatric cardiologist. It can happen in any age group of children. It's not necessarily any specific age. There is no difference between male and female. And the very important thing, the cardiac causes of chest pain is less than 2 to 5%. So before I ask the mother any question, their chance of the chest pain is cardiac related, you are talking about less than 2 to 5%. This is very important thing to mention while you are counseling the family. Because when they come to my clinic, they just want to make sure it is heart or not. Because when they look at the musalsalat, films, and they look at their grandfather or grandmother, she had or he has chest pain, and she went to the hospital. They said he has a heart attack. So any chest pain in a family mind, it is cardiac until proven otherwise. In fact, it is less than 2 to 5% in children to be cardiac. So if you look at the causes, idiopathic, you can see like a big variety in number. And also when I come to my clinic, I don't try to say, oh, costochondritis, idiopathic, calcium deposition. It just makes them more confused. It is very simple to say it is superficial musculoskeletal pain that like account for more than 90–95% of the chest pain in children. There's other causes, like especially for those who are coming to the ER, that chest pain is respiratory, pleurisy, pneumonia. If there's any history of trauma, it could be trauma-related and fracture. It could be related to reflux, hiatus hernia, and other things. But again, the cardiac cause is less than 5% of cases. So again, that's just a list of the condition that cause it, like costochondritis, trauma, muscle strain, bone abnormalities. The main difference here than the superficial muscle pain, the superficial muscle pain is sharp, stay for a few minutes, few seconds, increase with breathing. While costochondritis, trauma, no, it's actually chest pain that lasts there for a longer period of time due to a trauma or muscle damage. Sleeping grip syndrome, I have not seen any case of that. Maybe if you work in ER, we'll see it. Definitely asthma is a cause, definitely pneumonia is a cause, definitely pleurisy is a cause. If you have a high-risk patient like Marfan syndrome or someone who are in positive pressure ventilation, BiPAP, pneumothorax is a cause. If you have patients that come with significant shortness of breath and other things, and he has the risk of like obesity and other things, you have to look about pulmonary embolism as a cause as well. Don't forget drugs in teenager as a cause of chest pain due to coronary abnormalities. Gastrointestinal esophagitis, hiatus hernia, and foreign body could be the cause. If you look at the cardiac and subclassify them to a number of things, many things can cause it, like severe aortic valve stenosis. However, that patient will have difficulty with activity, shortness of breath. You will have chest pain mainly during activity. And if you listen to the child, you'll find a heart murmur. Hypertrophic cardiomyopathy also it can present with chest pain, but not alone, with other symptoms, chest pain, difficulty with breathing, exercise-related symptoms. Severe pulmonary hypertension, usually they present with very out of breath while walking, maybe some cyanosis, and then as part of that, they will have chest pain. I'm not sure mitral valve prolapse causing chest pain. It's in the literature, but I have seen many mitral valve prolapse with no chest pain, and have seen a lot of chest pain without mitral valve prolapse. Maybe it's a coincidence. For me, I'm not just sure if mitral valve prolapse causes chest pain or not. Coronary artery abnormality, definitely, like Al-Kaba, drug user, cocaine. When they come to the ER teenager, the story just like Effie, you might think about cocaine as a cause. There's like more serious things like aortic dissection as a cause of severe, like intolerable chest pain. Pericarditis is a common thing you have to think about, especially if there's any recent history of viral illnesses. If the chest pain increase with the forward movement. If you find by physical examination there is a pericardial rub, and ECG suggestive of that. Also, you have to think about arrhythmia as a cause. In small children, they cannot differentiate between the pain and arrhythmia. So maybe the feeling palpitation, but they describe it as a chest pain. So it's very important for me to ask which comes first, chest pain or the palpitation, to help me to differentiate. So the main goal for me as a cardiologist, and probably most of you, is to rule out a cardiac cause, but we should not ignore the other causes. I would say 95% of the diagnosis is reached through careful history and physical examination. You might need to do investigation if you are thinking about pneumonia, patient has cough, infection, or maybe history of trauma. Then you do chest X-ray to look for any rib abnormalities or any lung pathology. ECG, if you think about pericarditis, I think in أقل الإيمان to do ECG for any patient with chest pain. Echo, if you find a heart murmur or any other cardiac abnormalities. If it is, you are thinking it is chest pain or like arrhythmia, there is a palpitation in there, and maybe some dizziness and other things, you have to take it more serious, and you start to do like Holter investigation for arrhythmia. If the chest pain is exercise related, you might do exercise testing. I usually limit it to history and physical examination in most of my case. If I probably in my clinic, I never order chest X-ray. Probably in ER, you would order chest X-ray because I think in pneumonia. ECG, I always do it for any chest pain, just to make sure. So what is the important thing in history? So you have to ask the child itself, especially if it's more than 4 and 5, he can describe things more clearly than the family. على فكرة, most of the family come and say he has cardiac pain, ألم في قلبه. In fact, it is actually ألم في الصدر. It is a chest pain. So I always correct that information on the spot. When I say ألم في قلبي, I have cardiac pain, I say, where do you feel it? Here. Say, no, you have to describe it correctly. It is a chest pain. It is ألم في الصدر. That it's a part of the counseling. So then you have to describe the pain. Is it pressure related, squeezing, sharp, location? Is it central? Is it left or right? Is it moving from one side to other side? If it's moving sometimes left and right, that's not cardiac. When you ask about duration, the pain that sharp disappear quickly, that's usually not cardiac. You have to ask if it's radiated to anywhere else. How frequent? Is it something to do with the movement? Does it affect breathing? Muscle pain usually increase with breathing. If they breathe and the pain increase, that usually indicate muscle bone pain rather than cardiac. So you have to ask, is it exercise related or not? I already talked about if it's breathing related. If it's eating related, you have to think about reflux as a cause. Changing position will help sometimes. If there's any other non-cardiac causes like fever and cough, you might think about pneumonia. Definitely, you have to ask about other cardiac symptoms like syncope, dizziness, and palpitation. Now things become more cardiac related and become more serious. Also, if he's known to have bronchial asthma, is he known to have any other high risk thing to make him from one entity to another, you have to ask about the family history of any significant cardiac causes. Physical examination, the easy thing is just to examine, expose the chest, ask him with one finger, not all the hand, to pinpoint where is the pain. And then after that, you start to feel the area, if it's tender or not. You look at the muscle, if there's any like skin changes and other things, try to palpate the bone and muscle for anything, for the costochondral joint, for any tenderness. Tenderness in there tell you it is actually musculoskeletal. You have to listen to the heart for any arrhythmia, listen to the heart sound for any murmur. If there's any murmur, then you have to look for cardiac cause and you have to do an echo. If you listen to a rub, then it could be pleural and pericardial. You differentiate by asking to stop breathing. If the rub remain, that's cardiac. If the rub eliminated by stopping breathing, this is pleural. You have to look for other gallop rhythm, and you listen to the lung for any lung pathology like crackle and wheeze. ECG, again, I do it. The family feels sometimes more comfortable if you do like a simple investigation. If you start to think about pericarditis, another arrhythmia, ECG become important. Again, for me in the cardiology clinic, I never order chest X-ray. Probably in ER you would if the history is suggestive. That's just a patient with the chest pain that he has some aortic valve stenosis and he has ejection systolic murmur. Then the ECG in that case was showing left ventricular hypertrophy. You can see the R in V5 and V6 is very prolonged, and there is a deep Q wave in the inferior lead 2 and 3. This is suggestive of left ventricular hypertrophy. That's another patient with hypertrophic cardiomyopathy. There is a deep S in V1, and there is some interventricular conduction delay. What I'm trying to say here, you have to know some basic ECG. You cannot just order ECG and you don't able to read it. So chest pain, you have to look for any, you have to understand the criteria of left ventricular hypertrophy by ECG. You have to understand the criteria of pericarditis. I'm going to show it to you here, like ST segment elevation. You can see it here. This is ST segment in V4, V5, V6. You can see PR depression here. So PR depression, ST segment elevation, especially if it is generalized, you see it all over the leads, that's indicative of pericarditis. You can order troponin in that case to guide you for that, though you have to remember troponin is not sensitive. It could be elevated from other reason other than being related to pericarditis. This is just a case of Al-Kaaba. The presentation was like severe chest pain in the newborn, in the infant. Why it's severe? Because he was crying and he was really in pain. And you can see like deep Q wave in lead 1, AVL, V5, V6. This is called a lateral lead. So, and also some ST segment elevation, you can see it in V3, V2. So I show you the ECG because I see a lot of chest pain coming to the ER. Then in the middle of the night at 2 or 3 o'clock, doctor, what do you think about this ECG? It's absolutely normal ECG. I don't need to be waking up at night to look at the ECG to tell you the patient is actually having normal ECG. So if you work in ER, you have to know some basic ECG. There's one patient, I saw him in another hospital. They sent me the ECG. I was not available. The family got very concerned. Actually, sorry, that patient was seen in primary clinic, and they told him the ECG is like bizarre. He went to a private hospital, and they did ECG for him in that private hospital. I was not available. So he went to another private hospital, and he was admitted to the ICU. And when I saw him in the ICU in the second private hospital, he has absolutely chest pain that was normal, and the ECG was normal. So all the panic was around nothing. The patient went to PICU because someone told him there's like ST segment elevation, there's like heart problem. And when I went there, I discharged him home from ICU, PICU to the home. So reading ECG is very important for anyone dealing with ER and such condition. Echo, you have to do it for any patient with abnormal finding, heart murmur, rub, and other things. I already went through the cardiac causes that can be diagnosed by echo. You do Holter if you are thinking about arrhythmia. If the chest pain is exercise related plus dizziness and arrhythmia, then you might think about exercise testing when the child is big. You cannot exercise 5 years old child. You can exercise someone who is 10 and above. So when you refer to cardiology, to be honest, most of them, they will be referred to me because of the last thing, because the family are very anxious and they want to see cardiologists to say it is not cardiac. But the above 4 points help you. If it's exercise related, yes, you need to refer them to me. If there's any palpitation, dizziness, and other things, you have to refer them to me. If there's abnormal cardiac exam, if you did ECG and chest X-ray, you find it abnormal. If there's a strong family history of cardiomyopathy, long QT, or sudden death, then you have to refer to cardiology to make sure it is not cardiac, but more importantly, to reassure the family and tell them there is nothing to worry about. So in conclusion, chest pain is common presentation, rarely cardiac, most commonly superficial musculoskeletal without further complicating the issue to the family. History and physical examination usually, in most of the case, identify the benign nature of it. Investigation need to be tailored according to the history and physical examination and the red flag for cardiac evaluation if it's exercise related, if there's the other cardiac symptoms, if there is abnormal cardiac exam, abnormal chest X-ray, abnormal ECG, or concerning family history. And thank you so much.
Thank you so much, Muhammad, for your excellent presentation. If anyone has a question, you can write. And if not, we'll just move to our next speaker. You can stop sharing, Muhammad.
Okay.
So there is no questions. We will move to thank you, Dr. Muhammad, for being with us. وكل سنة وسعادتك طيب بمناسبة يوم التأسيس.
الله يحفظكم ويجزاكم خير ويحفظكم جميعا. وأنا أعتذر عندي موعد في المستشفى لواحد من أولادي بروح الآن.
تفضل. شكرا جزيلا. So our next speaker will be Dr. Warda Ali from Egypt. Dr. Warda is a consultant neonatologist, and she is the head of the Pediatric and Neonatology Department in Ahmed Maher Teaching Hospital in Cairo. Dr. Warda will give us a presentation about neonatal hypoglycemia, when to call the endocrinologist. أهلا بك دكتورة ورداء وشكرا على المشاركة.
أهلا بحضرتك دكتور نبيل. شكرا جدا للدعوة الكريمة. First, I would like to thank Dr. Nabil Shahata for his kind invitation to share in the 6th International Annual Saudi Germany Hospital at Riyadh webinar. Congratulations, yesterday was great as well as today. As usual, it's very fruitful. Wishing more success today and tomorrow, inshallah. This is my beloved hospital, the Ahmed Maher Teaching Hospital. Welcome to all of you to visit Ahmed Maher. Actually, my topic will focus on what the neonatologists need to be aware of concerning neonatal hypoglycemia, when and why they might have to call the endocrinologist. I have nothing to disclose. I will try by the end of my lecture to cover the different definitions of hypoglycemia, transition to extra-uterine life, and adjusting the glucose homeostasis. Is it common hypoglycemia, the incidence and the outcome of hypoglycemia, the pathophysiological etiology of hypoglycemia, and symptoms, clinical picture, whether we have to look for the clinical picture or we have at some time to screen to find to detect the hypoglycemia. What's the differential diagnosis of hypoglycemia, and finally the management, and at that point when we have to call the endocrinologist. Actually, hypoglycemia is the most common metabolic disorder in newborn and one of the few preventable causes of brain injury. The incidence of transient neonatal hypoglycemia is estimated to be 5 to 15% of newborns, and approximately 50% in at-risk babies. And shortly, we will discuss who are babies who are at risk. The incidences vary by definition, the age, and which population we are discussing. A prospective study in 2020 defined hypoglycemia as blood glucose less than approximately 47 milligram per deciliter, and it's found in about 47% of LGA, 52% of SGA, and 48% of IGA, infant of diabetic mother. The definition of hypoglycemia has been changed over time. As you see, in the 1960s, blood glucose was about 20 milligram per deciliter, and in 70s up to 40 milligram per deciliter. From 1988 and onward, concentration 47 milligram per deciliter became accepted by many neonatologists. As you see, it is different from one type to another. Actually, we are not concerned by but by a number, but we are concerned with the hypoglycemia definition based on treatment recommendation target threshold value, at what value we need to interfere. In late preterm, the American Academy of Pediatrics presented this issue and mentioned that in the late preterm, the infant of diabetic, SGA and LGA, they divided them whether they are symptomatic, then at any age, hypoglycemia will be less than 40 milligram per deciliter. If this child is symptomatic. If the child is asymptomatic, then whether the baby is from birth to 4 hours, the number is 40 milligram per deciliter. From 4 hours to 24 hours, hypoglycemia will be considered at less than 45 milligram per deciliter. On the other hand, Pediatric Endocrine Society mentioned a critical phrase: a plasma glucose concentration, hypoglycemia is a plasma glucose concentration low enough to cause symptoms and signs of impaired brain function. Then what is this number at which there will be impaired brain function? In infant, it is less than 60 milligram per deciliter because normal threshold for neurogenic response is 60 milligram per deciliter. Neonate with persistent hypoglycemic disorder, the Pediatric Endocrine Society will be concerned with whether the high-risk infant without a suspected congenital hypoglycemic disorder will divide them, whether it's less than 48 hours, then hypoglycemia will be defined at less than 50 milligram per deciliter. If the baby is more than 48 hours at birth, then hypoglycemia will be less than 60 milligram per deciliter. Neonate with suspected congenital hypoglycemic disorder I just want them to be at a higher level to avoid the complication of hypoglycemia. Then they will define hypoglycemia at level less than 70 milligram per deciliter. As you see, exact glucose value which defined hypoglycemia remain controversial. Which glucose value and under what condition neurological damage occur? We are very concerned of the impact of asymptomatic hypoglycemia on neurodevelopmental outcome. A very critical and important actually definition can be glucose delivered or availability, which is inadequate to meet glucose demand. We are rich or poor, not according to what we have, but about what we demand, what we expense. In a very important study mentioned here in 2022, hypoglycemia can cause neurological impairment, increased risk of poor executive function and visual motor function, It's critical to recognize hypoglycemia and initiate treatment to avoid this neurological impairment. This was done in was mentioned in the child study, which is children and hypoglycemia and their late developmental study. Let me remind حضراتكم, executive function is the mental process that enable us to plan, to focus, to juggle multiple tasks successfully. And visual motor function involve the ability to coordinate vision and movement of the body. This is what might be impaired by the asymptomatic hypoglycemia, as mentioned in the child study in 2022. Another studies mentioned that in 2022, they mentioned that neonates at risk of hypoglycemia were, if they were screened and treated if needed, they will not significantly associated with low education achievement in mid-childhood, as later we will discuss that the hypoglycemia will not present early, it will be presented in the mid-childhood, not in the early childhood. To understand and explain what this great variation in the glucose level, let's remind each other with the glucose homeostasis. Glucose provide approximately 60 to 70% of fetal energy needed. Fetal glucose derives from maternal circulation to maintain fetal glucose level at approximately 2/3. As we all know, the fetus reflect 2/3 of the maternal level and even at birth. At birth, there is abrupt interruption of the source of glucose, and subsequently, the newborn must rapidly respond by glucogenolysis, the hepatic stores, or gluconeogenesis, and utilize exogenous nutrient from fed to maintain the adequate glucose level. During this normal transition, it is a normal transition. In a normal newborn, glucose level fall to a low point in the first 1 to 2 hours. It will be low as 30 milligram per deciliter and then increase to more than 45 milligram per deciliter, then stabilize at mean level from 65 to 70 milligram per deciliter by 3 to 4 hours. It has mentioned in this very important publication, glucose in well babies. It's mentioned below. It's the trial published in 2020. It is the first accurate study on transitional neonatal hypoglycemia that explained that it's very accurate, and they measured the blood glucose twice per day. And they mentioned that normal value in the healthy baby vary significantly. As many as 40% of babies had one value of blood sugar less than 47 milligram per deciliter in the first day. Transient neonatal hypoglycemia may last for 4 days, thus observing baby at risk of hypoglycemia during these 4 days. Also, investigation and calling for the endocrinologist for causes of persistent hypoglycemia may be preferred planned after this period. To understand what's going on and why there is the impact of glucose level, there are several factors affecting the glucose level, which are the inadequate glycogen stores, the hyperinsulinemia, and the increased glucose utilization. That's why we can explain the pathophysiology of hypoglycemia as inadequate glycogen stores, as seen in the baby, the prematurity, in intrauterine growth retardation, small for gestational age, and polycythemia. Will explain shortly why it causes hypoglycemia. If there is increased glucose requirement, the pathophysiology, this will be in sepsis, then I need more glucose to face the disease, congenital heart disease, hypothermia, neurological problems as periventricular hemorrhage and convulsion. Hyperinsulinism, this is the very common infant of diabetic mother, perinatal asphyxia, LGA, large gestational age, even if there is no maternal diabetes mellitus. Erythroplastosis fetalis, some of the syndromes like Pickwies-Widman syndrome and other syndromes will be mentioned shortly. Maternal drugs, very common beta blockers, the most commonly used beta blockers and anti-diabetic drugs. Other as congenital hyperinsulinism. Again, there is inborn error of metabolism may cause as hypoglycemia, whether carbohydrate, fatty acid, or amino acid metabolism. There might be contrarregulatory hormone deficiency, panhypopituitarism, hypothyroidism, growth hormone deficiency, adrenal insufficiency. Polycythemia can cause hypoglycemia. Either there is high glucose utilization by the increased mass of red blood cell, or it is a fault or decreased amount of serum per drop. Thus, the lab will normal glucose level on lab analysis, because we will measure the serum and not the baked RBCs, the RBCs itself. Some syndromes might cause either transient hypoglycemia or persistent hypoglycemia, like Beckwith-Mind syndrome with the macrosomia, mind microcephaly, omphalocele, macroglossia, hypoglycemia, visceromegaly. It's very common. The Kabuki syndrome, we have to be minded with the postnatal short stature and the other feature, Costello syndrome. We just want to highlight and note that if there is abnormal feature or whatever specific for each syndrome, might there be hypoglycemia and persistent hypoglycemia, and the need to consult an endocrinologist, short stature, as well as Soto syndrome. Anyway, with squint, the goal, whether it is transient or persistent hypoglycemia, we need to correct blood glucose level in asymptomatic patient to prevent symptomatic hypoglycemia in at-risk patient, to avoid unnecessary treatment of infant with physiological low blood glucose during the transition to extrauterine life, which will self-resolve without intervention, as we mentioned in the GLOW study. We need to identify newborn with a serious underlying hypoglycemic disorder and prevent long-term neurological sequelae of neonate hypoglycemia, as we mentioned in the mid-childhood. We can do this by symptoms, by screening, by lab, and there are other investigations we'll mention. Unfortunately, symptoms that have been attributed to hypoglycemia are completely non-specific. We'll mention it shortly. Many infants have no symptoms even and they have hypoglycemia. As you see, symptoms might be irritability, tremor, jitteriness, exaggerated motor reflex, high-pitched cry, seizure, lethargy, hypotonia, cyanosis. All of them are completely poor feeding, apnea. All these are completely non-specific. Thus, we need to screen. I have to look after and know is there hypoglycemia. If you are going to speak about screening, then there's some question that I need to answer: who to screen, when to screen, and why to screen. Maybe why to screen, we answered it already. We want to screen them to avoid the neurological impairment in neonate with asymptomatic hypoglycemia later on in the mid-childhood. And another question we need to answer is how to screen. Let's start with, we need to, who we require screening neonate at increased risk of hypoglycemia, whether they have symptoms of hypoglycemia, LGA, perinatal asphyxia, whether to birth asphyxia, cesarean section for fetal distress, they needed to be investigated and screened for hypoglycemia, preeclampsia, eclampsia, IGR, SGA, meconium aspiration syndrome, hypothermia, and polycythemia. Again, if the baby is preterm, premature, post-mature, infant of diabetic mother, family history of genetic form of hypoglycemia, as we mentioned, congenital syndrome or abnormal feature, whether the syndrome is. Let's mention this step by step. If I'm going to screen and manage the postnatal glucose homeostasis, I will start if the symptoms if the baby is symptomatic and or blood glucose less than 40 milligram per deciliter or asymptomatic. We mentioned already the symptoms, the non-specific symptoms, the irritability, the tremors, the jitters. At that point, we will first divide these babies. If the baby is from birth to 4 hours of age, I need to initial feed the baby, and we mentioned that we can read up to 30 milligram per deciliter, and maybe this is normal. At that time, I need to start early feeding to this baby, and after first initial feed, if the blood glucose maintained below 25 milligram per deciliter, this means that I need to give IV glucose. If after first fed it started to increase, maybe I will continue feeding and then I will not give IV glucose. If this baby is from 4 to 24 hours of age, I will continue feeding every 2 to 3 hours and screen glucose before each feeding, I'm aiming to screen, to pick up babies less than 35 milligram per deciliter, because these babies will need to give them IV glucose. If they are increasing and reach 45 milligram, then it's go on and go feeding this baby and avoid giving the glucose. The target glucose screen is to increase more than 40 milligram per deciliter before routine feeding. The glucose I'm going to give is 200 milligram per kg, dextrose 10% at 2 milliliter per kg, and IV, the GI maintaining IV infusion, a GIR 5 to 8 milligram per minute, with a fluids 80 to 100 cc per kg per day. Then how to screen? We use the simple way, the reagent test strip, point of care bedside reagent test strip, point of care glucose meter. Glucose is obtained by heel stick and a drop of blood is placed on the strip. It read by visual color change and by the glucose meter of bedside. Please remember that sampling blood from unwarmed heel may result in falsely low glucose reading. We need to take this, should be done on the most medial or lateral portion of the plantar surface of the heel, avoid the posterior curve to avoid calcaneus injury, and the lancet are designed to enter no deeper than 2 to 3 millimeter. This way is quick, inexpensive, practical, very practical, but please remember that the reading is based on whole blood, which can be 15 milligram lower than the plasma blood glucose. And it's not accurate, especially at the low level, below 45 milligram per deciliter. The FDA mentioned that 95% of glucose results have to fall within 15 milligram deciliter at glucose less than 75. It may be more 15 or less 15. Let's say, therefore, an infant with a glucose of 40 milligram per deciliter may be 25 or 55. The reading are affected by the hematocrit value, high hematocrit value, presence of bilirubin, high viscosity, and also all this might give a low level of glucose. Thus, we need a lab data. It's the most accurate method of measuring the glucose concentration. The result may not be available quickly enough for rapid diagnosis, thereby delay the initiation of treatment will take time, and we want to avoid this hypoglycemia with its impairment. There is several points to be taken when I'm dealing with the laboratory diagnosis. I just want to emphasize on one point, which is that the plasma glucose can lower by 6 milligram per deciliter per hour if the sample is not processed soon in the laboratory. So I can take the sample and keep it without centrifuge the sample and get the erythrocyte, because the erythrocyte in the sample will metabolize the glucose. Sometimes we use the subcutaneous continuous glucose monitoring. It is just used in research. There is, for the persistent hypoglycemia, there are more studies to be, investigation to be given. I will not focus on the persistent hypoglycemia, but just I will highlight who to exclude that there is persistent hypoglycemia, and I need to call to the endocrinologist if there is severe hypoglycemia out of the figures we mentioned, or if inability, I'm unable to constantly maintain preprandial blood glucose concentration more than 50 milligram per deciliter, up to 40 hours of age, and more than 60 milligram per liter after 48 hours. Or if there is family history of genetic form of hypoglycemia. If hypoglycemia persists for more than 4 days, endocrine evaluation may be necessary to specifically evaluate for hyperinsulinism and rare causes of hypoglycemia, the endocrine causes mentioned. I will skip, it's not my scope to concentrate on the endocrinology investigation. At that time, if I suspect persistent hypoglycemia, the endocrinologist will ask for the following, but for the sake of time, I will escape all this lab and all investigation to be done, because I want just to emphasize that the case will go on investigation, the rare causes of hypoglycemia. أنا عارفة أنا مش عايزة أخد أي وقت ولا دقيقة زيادة.
Take your time. We still have good time. No problem. You just, if you want to say anything, take your time. It's very nice presentation and important also.
Thanks, Dr. Nabil. Actually, imaging and other studies might be needed, and actually we must be aware of the investigation that the endocrinologist will ask for it. Ultrasound to detect the pancreas, to look for the adenoma. The echocardiography may show hypertrophy of cardiomyopathy in infant of diabetic mother, transient hyperinsulinism. We may need head MRI, magnetic resonance imaging, to rule out pituitary or hypothalamic neoplasm or congenital abnormality. Again, I will mention later on the MRI discussion on it to discuss the changes of hypoglycemia in the MRI, whether it is recommended or not. Then we come now to the differential diagnosis. The differential diagnosis of hypoglycemia can be classified clearly based on the duration of hypoglycemia, whether it is transient hypoglycemia or persistent, mainly if it's often difficult to distinguish. Actually, on the first 2 days of life, it will be very hard for me to distinguish whether it is transient neonatal or hypoglycemia or it is persistent hypoglycemia. The majority of hypoglycemia in the newborn period is transient and non-pathological and lasts only for 2 days. We need again to rule out other disorders that may mimic hypoglycemia and cause the same symptoms of hypoglycemia. As we mentioned, that the symptoms is completely vague and non-specific. These symptoms that might be sepsis, then we can be, the clinical picture is that of sepsis or sepsis causing hypoglycemia and having the same clinical picture. Or again, CNS diseases, toxic exposure, metabolic abnormality, electrolyte disturbance, pyridoxine deficiency, heart failure, renal failure, liver failure, all of this will cause clinical picture mimic hypoglycemia. Then we need to have anticipation and prevention when possible are the key to the management of infant at risk of hypoglycemia. I don't want to have hypoglycemia at all. The management will be simply feeding dextrose gel, fluids, and these are the concern of the neonatologist. On the other hand, there's some medication will be, I will just mention them because might be I need to start the medication till the endocrinologist manage. Although the use of this medication on the right side, almost always I'm in need of the endocrinologist. And even I will ask the surgeon to have pancreatectomy in some cases. The approach of management of hypoglycemia, it needs to be stepwise process depending on the presence or absence of signs and symptoms and the response of the infant at each step, again, and the level of glucose I want to reach. Asymptomatic infant, we know that glucose level in 30 milligrams per deciliter will respond to feeding. I don't need to give it's not needed to give him IV fluids. Whether I will give breast milk and formula milk, I will discuss this point. A follow-up blood glucose should be measured, as I mentioned in the diagram, 1 hour after the start of feeding. If the glucose level does not increase, then here I don't want to hesitate. I will go no more trials. I will give IV glucose infusion is required. Breast milk. Breast milk should be initiated with the first hour of birth as soon as the mother and the baby are stable. This is the golden standard and this is the best for every condition for both of them. Remind حضراتكم that breastfed infant have lower glucose level, but it is normal and I don't want just to rise the blood glucose. The early introduction of milk feeding preferable because it will result in rising the blood glucose, maintaining normal stable level and avoid rebound hypoglycemia. Feeding of glucose, water is not, to give glucose is not recommended. And again, the use of dextrose gel to prevent hypoglycemia. There is a diagram to show the doses, but actually I remove it because the Cochrane review in 2017 found insufficient evidence so that practice cannot be recommended because I cannot adjust the glucose very accurate. The IV fluid indication, I will discuss the indication, how the bolus, the continuous infusion, the GIR, and how to monitor. When is indicated to give IV fluid? If there is inability to tolerate oral feeding, or there is persistent symptoms of hypoglycemia after feeding, or oral feeding failed to maintain the normal glucose level. I will give 2 milliliter per kg, as mentioned, exhaust 10% in IV fluids, and continues the infusion of GIR or 6 milligram per kg per minute, and recheck after 20 to 30 minutes after IV bolus, and then hourly until stabilize this baby. According to the concentration of the fluid I'm giving and the fluid requirement of this baby, I will differ from the concentration of my fluid, but take in consideration that infant who depend on high infusion rate, more than 12.5%, will need a central venous catheter. After glucose level has been stable in the normal range, taper the glucose infusion rate. IV fluid should be weaned slowly while introducing the feeding and advancing the feeding. Just to remind حضراتكم ببعض الميديكيشن that might be used, the hydrocortisone, it's mentioned in the literature, it's historical at 10 milligram per kg, mode of action. I will not emphasize that it is the role of the endocrinologist, but again, before administration, consider drawing the cortisol level. There is some hints that we have to be put in our mind. Diazoxide is the first treatment of choice for persistent pathological hypoglycemia. Its dose, it's given for the persistent hyperinsulinemia. It decreases insulin release. It takes up 5 days for positive effect to be seen. We need to know this message. And there's side fluid retention as a side effect, and the long use will have increased excess body hair. The octreotide, with its dose, I will just skip this long-acting somatostatin analog that inhibit insulin secretion, prefer over somatostatin because it has shorter lifetime. Use diazoxide does not successfully control glucose level. And again, the glucagon, again, all this will just have to be put in mind. Maybe it needs one lecture for for persistent hypoglycemia to discuss all these points. As we mentioned, we might need to refer to the surgeon if the medical treatment failed to control hypoglycemia and I have a focal lesion in the pancreas. I might need subtotal pancreatectomy. Here, I try to go rapid in the first part because to emphasize on this slide, because this is very important. This is our role as a neonatologist, the discharge recommendation. The American Academy of Pediatrics emphasized that if inadequate postnatal glucose homeostasis is documented, make sure the infant can maintain normal plasma glucose concentration on routine diet for at least 3 fed. I need to measure the glucose before feeding the child for 3 consecutive fed. It must be within normal. This is very important. And the Pediatric Endocrine Society mentioned that any high-risk neonate with a suspected congenital hypoglycemia disorder on normal fed, they need even to consider safety fast to 6 hours. They will fast and measure the blood glucose for after 6 hour fasting, and they will not discharge this neonate except they maintain glucose more than 60 milligram per deciliter. If they did not succeed to do this, they need additional investigation must be necessary. Any infant with known genetic or persistent form of hypoglycemia before discharge, obtain a consultation, do a safety fasting test to make sure that the infant can maintain glucose even more to be more than 70 milligram per deciliter after feeding is missed. I will escape a feeding and see that the blood glucose will not decrease less than 70 milligram per deciliter. How long to control blood glucose in preterm babies? We are confronted with these babies. Please remind this, it's very important slide. We usually monitor blood glucose in the first day, but take care. Premature newborn, particularly those with very low birth weight, can present episode of hypoglycemia for prolonged period, sometimes until term-corrected age. How many babies, for how long do we monitor our preterm babies? Then the long-term follow-up and evaluation. They must be followed in the childhood for the neurodevelopmental status, A systematic review show no difference in the neurodevelopmental impairment in early childhood, but significant neurodevelopmental impairment in the mid-childhood, later in the form of visual motor problem, poor executive function, we discuss it, low literacy, and numeracy, dealing with numbers. I mentioned you that there is MRI. Would you use it? Children exhibit a typical pattern of CNS injury, particularly in parieto-occipital cortex and subcortical white matter. It is difficult here to clinically isolate hypoglycemia from hypoxic ischemic encephalopathy plus hypoglycemia. Some clinicians believe that it is useful to obtain MRI scan on infant with symptomatic hypoglycemia, but actually it's not standard of care now. To summarize my main points, normal level of blood glucose may be different among term and preterm, vary with the days of life. Hypoglycemia can be defined as glucose availability, which is inadequate to meet glucose demand. Hypoglycemia is the most common metabolic disorder that can cause neurodevelopmental impairment. The target glucose is that I need to take a decision according, and it differs according to the risk factor of this neonate, the gestation, the birth weight, the age, the predisposition to persistent hypoglycemia, and my target glucose value. Plasma glucose is the golden standard for discussion. Whole blood glucose measured at the bedside point of care device may be approximately 15% lower than plasma level, and as we mentioned, is affected. Asymptomatic at-risk infant are those the preterm, SGA, LGA, infant of diabetic mother should be screened for hypoglycemia and promptly treated to avoid later on neurodevelopmental impairment. Infant who fail to maintain blood sugar level, normal level for age and require IV fluid are at risk of persistent hypoglycemia, as we mentioned, after 4 days, and must be investigated for a cause and call the endocrinologist to investigate. These are some of my references, and thank you.
Thank you so much, Dr. Ragda, for this excellent presentation. I just have one question from Dr. Hala Youssef. She's asking if the baby has no IV access, can I give glucose, dextrose, 10% per oral?
It has been mentioned, and maybe for the short of time, I remove this slide, and it mentioned roughly how much I can give, how many cc's will give how many glucose, although it is not recommended. No evidence base for this practice.
Okay. Then I have a question from my side. In the first 4 days, when you are waiting for the endocrinologist to come, will you withdraw some of the investigations like cortisol AM and PM and send insulin C-peptide or something, or you will just start to treat with bolus, and which may change your results after the 4 days, and the endocrinologist, when he will come, may have results which are not the base or after your correction. This is one question. The second, when you evaluate the baby, a symptomatizing baby who got seizures and jitters and neurological manifestations, and we are screening with MRI, and if you will not screen before discharge, will you refer him to the neurologist soon, or he will wait until if he will be symptomatizing and come back to the neurologist?
Okay. First question, it was discussing, I'm sorry, I forgot.
Will you withdraw any investigation in the first 4 days, or you will just wait and try to maintain it?
Actually, my message for this lecture, the baby with transient neonatal hypoglycemia will respond rapidly and simple that I can manage by feeding. If it's first step I can give, then I'm feeding. If I'm reading very low glucose level and I'm giving the GIR the normal requirement, here I have to discuss. And the part I tried to escape quickly, I will never give hydrocortisone except when I withdraw the cortisol level. We have to be minded by this issue before asking a consultation by the endocrinologist. We need to be put in mind. This is the first question. Okay. The second question, I've been mentioned the MRI, the CNS investigations. Actually, it may be this part need more and more research, because the finding in the CT, in the MRI, they cannot clarify or differentiate between this hypoglycemia. This is hypoxic ischemic, because actually many diseases will cause even more hypoglycemia. The requirement for glucose will be increased. That's why the changes in the MRI or the CT, whether it is due to hypoglycemia or the underlying disease that causes hypoglycemia. For my opinion, these cases, and again, my message here, don't take any baby that there was difficulty in transition to homeostasis. Follow him later on. As I clarified more than one time, it's not in the early childhood, it is even in the mid-childhood. It will affect the cognitive function. It will affect the executive function. There's factors we are facing this child. Maybe they are underdiagnosed because we don't have a tool to specify that this is the cause of hypoglycemia.
Good. Well, just my opinion here, if you will do the MRI within the first, after the first week, you will have at least a baseline MRI for the brain of the baby while you are discharging him. Sometimes this baby has a mixed hypoglycemia and hypoxia. Hypoxia will at least be showed or presented in the MRI after 1 week. We have here, for example, this can be more in countries where the medico-legal aspect is taking a good part of the practice, because I have a case here. It was before I came to this hospital, and they came to claim 3 years after delivery. They are searching, have this baby was prone to hypoxia around the delivery or not, because the baby has CB, which is not till now diagnosed. They did not make full diagnosis. But the first impression when you will go to a pediatrician, he will easily say this baby has hypoxia or something, اللي هو نقص أكسجين. ده نقص أكسجين عند الولادة، فهيروح المستشفى بتاع الولادة يشوف عنده كذا. If you have a document and if you have an MRI or something like this, when I attended the process, for example, for the OB-GYN, they just went to the note of the pediatrician, how was the baby delivered, and unfortunately, our resident wrote that the face was congested. Okay, so that means the delivery was obstructed or something. Now we are speaking 3 years back. Then when she came, the OB-GYN consultant asked her to show her the CTG. And there was actually, after 3 years, the CTG, I don't know if it was not recorded or what was not done or what not scanned on the file of the patient. Okay. But if you have at that time a normal CTG and normal records for the baby, you are okay. If you could not prove this, then you will have it medico-legal.
Okay.
That's why if I have my experience and even my recommendation, if you have the ability to screen your baby neurologically and to screen him with MRI, do, and have a baseline. Then you can wait, maybe like you told us, after 10 years, you will come back. The problem is that we are not so accurate when we are prescribing to the family. The pediatrician will tell him نقص أكسجين، بس نقص أكسجين ده بالنسبة لهم يعني عند الولادة. فهو ده
I have a comment.
Yes.
Actually, we are dealing, it's a hidden, you are discussing hypoxia, نقص الأكسجين. What I do believe that I'm discussing a hidden disease. لأن أنا بيبي الهايبوغلايسيميا الموضوع كبير جدا، لأن في حالات من حالاتنا بتعدي asymptomatic، مجرد إن أنا اتأخرت في الرضعة شوية وما رضعتش البيبي بسرعة، البيبي ده اتعرض لهايبوغلايسيميا، وأكيد في كونتروفيرسي زي ما حضرتك شفت 30 ملغ كان نورمال في أول ساعة. انما later on لو سبته انا مش هعرف اشخصه، حتى لو عملت سي تي او whatever investigation هتطلع نورمال، لان انا بتكلم في cognitive function، في executive function. طفل عند 10 سنين مش بيستوعب كويس في المدرسه، مش علاقاته الحركيه او الفيجوال كوردينيشن بتاعته affected، بيقع كل شويه. احنا بنسمع الكومبلينز دي كتير دلوقتي من الامهات. هل احنا في hidden hypoglycemia asymptomatic واحنا سايبينها؟ كانت يعني أهمية إن أنا كنت أبريزنت الموضوع ده في النقطة دي. يعني we need to investigate later on. فاللي أنا عايزة أقوله إن الأكسجين ده أنا هعمل سي تي وألاقي فايندنج، لا هو أنا هعمل سي تي مش هلاقي حاجة، ومشكلتي هتطلع عند سن 10 سنين بطفل استيعابه قليل.
هو لا برضه ستيل في مشكله في موضوع السي تي عشان مصر بالذات، يعني فعلا ما اعرفش ليه في مصر الاطباء مصممين على السي تي.
مع انه حاجه
السي تي cannot detect الهايبوكسيا يعني cannot study the soft brain tissue in early infanthood. With CT I'm searching for bleeding, for brain edema, for something which is also, يعني I will not do a CT and put the baby under this hazards of very high radiation just to see if what a cranial ultrasound can see.
The same model.
If I will go to imaging, MRI is the best and it is the recommended one. Thank you very much, and still it will be يعني depending on the facilities and everything, but I mean if you have the facility, do.
That's good. Agree.
Thank you so much. Thanks. You can stop sharing. Thank you, Dr. Ragad. I just will see if we don't have any more questions. So thank you for being with us, and you can stop sharing. We'll move to our next speaker. Will be Dr. Khalid Al-Ghamdi. Dr. Khalid Al-Ghamdi is a consultant pediatric GIT in security forces in Riyadh. He is one of the most eminent GIT consultant in endoscopy also, and he will speak to us about infantile colic. Assalamu alaikum, Dr. Khalid, and you can start.
عليكم السلام ورحمة الله وبركاته.
وكل سنة وحضرتك طيب بمناسبة يوم التأسيس، ومتشكرين لمشاركتك معنا.
الله يعطيك العافية. Is my voice and my screen is clear?
Everything is okay. Go ahead.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the groups for inviting me again to give a talk tonight. It's really it's my pleasure to be always with you, and I hope I will continue like that. It's a great actually symposium, and it's really something I'm very thankful for all of you, especially Dr. Nabil. So let us go ahead and talk about one of the common issues in pediatric, and most of your clinic is having this issue very frequently. Maybe you will see many babies with that issue. So I will go through the topic very quick. So we'll just start to save the time. So infantile colic. It's infantile colic. We should know that it's a functional gastrointestinal disorder. They consider it now. It's included in all function in Rome criteria for functional gastrointestinal disorder in infancy. What that means, there is nothing wrong with the organ. It is a lot of interaction. We'll talk about it. Most of crying during the first 3 months of age. So, and later on, they will get better. And when they studies the crying generally in babies, they found that the babies, they cry like 117 to 133 minutes per day during their first 6 weeks. And later on, by age of 10 weeks, their crying will start to come down. However, these issues as the problems or visiting to clinic is counted as 20% worldwide. So we are not the only one. Peaks usually at around age of 6 weeks and usually resolved by 3 months. However, it can take up to 6 months. Male or female is the same. It is not correlates to type of feeding. It's not correlate to gestational age or the socioeconomic status. So that is not correlation. As you see here in the diagrams, is one of the 3 studies here, all of them, as I mentioned, the peak usually start at 6 weeks. And once they reach to 10 weeks, they get much, much better. Definition: for very long periods, we depend on Wessel definition, which was in 1954 when he divided that as paroxysms of inconsolable crying. So it is inconsolable. If you can console them, that's not. So if you say the mother cannot bring him down, this is what is infantile colic actually. And he also put it as more than 3 hours or equal per day, for more than 3 days or equal per weeks, for more than 3 weeks. In otherwise healthy and well-fed baby. However, recently, Room 4 criteria put their definition, and actually now in GI, we depend on Room criteria as reference for all functional GI disorders. So it's infant who is younger than 5 months of age, who present with recurrent prolonged period of infant irritability, fuzzing, or crying, reported by parents that occur without obvious cause and cannot be prevented or resolved by caregivers. Without evidence of infant failure to thrive, fever, or illness. That is for us as a clinician. This is the definition. So if you have very prolonged irritability, crying, very difficult to control, you cannot resolve it, in otherwise healthy growing baby, so we are dealing with infantile colic. However, in the definition, they add these for those researchers. Infant has cried or fussed for more than 3 hours per day during more than 3 days and 7 days. And they have to, should be depend on 24-hour diary record. So the last 2 is mainly for researcher. So if you have a look on babies, you will see him in that position. You can see the fist clenching with prolonged crying and hips flexion. So with these pictures, always the mothers think the problem in his tummy, and that's okay. We know the problem is there. Most of the times after feeding, but it can happen throughout the day without specific time. However, evening times, they consider it even more. Your rule as the doctors to get a very good history to rule out any treatable condition or serious condition. So you'll ask about infant feeding, stooling, urination, vomiting, sleeping better. You'll ask about perinatal or perinatal history, including risk factors for sepsis. And you will go through the psychosocial history, especially in the family. So you will, when does the crying occur? How long it does takes? What do you do when the baby cries? And how and what you feed the baby? And how do you feel when your baby cry? This is very important, very critical. And how has the colic affect your family? So sometimes the stress on the family more and more because of some issues, like the father, he cannot sleep in the room because the baby crying all the time. So that he is putting more stress on the mother and on the family. Then you will start examination, full examination from head to toe. You have to observe the infant and parent interaction, how they deal with the babies, assessment of temperaments, growth parameters, assessment of any identifiable causes, looking for hernia, for any sign of child abuse, or so you have to examine fully. Once you get very good history for a very good exam and everything indicate healthy looking baby with normal examination, so you are dealing with infantile colic. As I mentioned, the diagnosis usually in those between 3 weeks to the 3 months, and it is intermittent and it is very difficult to control, and worse crying after feed or during the evening time. Diagnosis, paroxysms, it has been there in the definition for a very long time, but nowadays is not necessary. They describe the crying usually is different, very loud, and this is the criteria for it. So that is one of the features for infantile colic crying. They are hypertonic during the crying, and as I mentioned before, difficulty consoling. So we don't need that. So the etiology, we don't know it exactly. And once you don't know the cause, you will have a lot of theories, some of them logical and some maybe not to you, but the people, they were looking for what's the cause. So is it cow's milk protein allergy? Actually, that was not proven because some studies showed improvement on hydrolyzed formula, but these studies limited and not enough to consider it. So still we are not sure, and actually most of the experts against that. What about intolerance to other substances in the maternal diets, which especially those green vegetables, cow's milk, onion, chocolate, which lead to more of colonic gas production? It was given as a theory, some studies, but wasn't enough to confirm it. They start for that to study the gas production. Is those who have infantile colic, they produce more gases. One study showed that, but in other studies didn't show that. The other things also, they found positive lactulose breath hydrogen test in those who doesn't have colic. So it's not necessary. It could be a part, but not the only factor. What about lactose intolerance? That is idea came because positive lactose hydrogen breath test, but the expert later on found that is the positive of this test was due to the high level of colonic bacterial fermentation at this age, which is normal. Poor feeding technique, definitely it's playing a role. if it is there, but most of the time you will not find any problems with the feeding technique. So, but you need to make sure the baby is not underfed or overfed, and the mom is also frequently burping him. Make sure he's not swallowing air many times by using empty bottle or the pacifier. And usually those found it more with those new mothers with the first babies, the technique issues. Hormonal, they study the serotonin, and we know that serotonin is very important in affecting the mood and social behavioral and general population. So they found it's high in babies, but we are not sure is that normal or not, because even in control group, they have the same. The other issue, is it a part of neurodevelopmental issues on those babies? Could be normal emotional development. And what support that those who have infantile colic when they are baby, they tend to have a good group of them to have migraine when they became adults. Some they bring the idea of missing the 4th trimester, which is supposed to be quiet in his mother tummy, which not like the real life. However, psychosocial, it is definitely playing a role. So you have to see the interaction between the babies and the parents, looking for any anxiety in the family, maternal smoking, maternal or paternal depression, and advanced maternal age. And it's very clear, even for me, I noticed that is first mother or old mother, they are the most mothers who bring babies with this complaint. Psychosocial, as I mentioned, you have to go through the psychosocial history, make sure about the marital relationship, any stress in the family, any lack of self-confidence during the pregnancy, dissatisfaction with the delivery, level of family stress. All that will play a role in increasing this issue. Then the main and very important rule is the dysbiosis and inflammation. I think this is playing a major role here, but the cause is whatever mentioned before, it's considered causes for dysbiosis. So they found that when they studied the calprotectin and compare between the colic and normal, the calprotectin was high on those who have colicky abdomen in one study, but in another study, it didn't show this different actually. So the other things they found, when those babies start to improve, their calprotectin actually it's decreased. So that is why they put the idea maybe there is some inflammation. And this inflammation most likely due to the dysbiosis. We know that is the microflora or in babies, it doesn't have very crowded organisms. So the dominant organism or microflora in newborn, usually 3. With growing, it will increase till during the adult time. And actually babies reach to the flora of adults, or I mean bowel flora of adult by age of 3 years. They have like 400 dominant actually organisms. So in the beginning or in the first few months is very limited diversity in the organisms. And what is playing a role in dysbiosis? Definitely genetic, postnatal maturation, medication they use, dietary choices for the babies and for the mother who fed the baby, antibiotic, lifestyle choices, and psychosocial stress. So once you have those good microbes, and they are more than the bad microbes, then you will have normal gut microbiota. But if the dysbiosis is there and bad microbes actually more, then you will have a lot of issues like gut barrier disruption, tissue damage, and bacterial translocation, and increase or release of inflammatory cytokines, which can lead to inflammation and pain. When they studied the flora in those small babies, they found really that is the colicky babies, they have very limited number of a good organism like the actinobacteria, and mainly here we talk about lactobacillus and the bifidobacteria. It is very, very low compared with the pro-inflammatory organism like the Klebsiella or E. coli. So with these all causes, ideas behind the infantile colic, what to do? At the end, reassure. Reassure, because we are not talking about organic disease, we are talking about functional GI disorders. We are talking about interact between the bowel and the brain, but there is nothing wrong with the baby. Reassurance is very important, and many times the family, they want to hear that only from you. But definitely they will not take it, or they will not believe you if you will not take a good history and doing a good examination in front of them. Because to let them really believe that is their babies is healthy, you have to do full history and examination. Ask the mother always to bear the babies, to put a fixed time for feeding, because if he cry because of gases and give him milk again, that will increase the pain. So they have to put a fixed time for feeding. They have to avoid over or underfeeding. They have to avoid the pacifier or sucking empty bottle. That will increase gases. Swaddling is a good technique for our mothers. Long time they do it and it helps. The white noise is very, very good technique. Just anything, put it with the noise around the babies, they will come down, it works. And gentle stimulation, and sometimes some mother or they do a massage, the tummy massage, which is okay. The other things like the acupuncture, the studies, we don't have a very good studies to recommend or to be against that. And also the chiropractic, we don't have enough studies to recommend that. What about our culture? Our culture, usually they use the complementary medicine, like the fennel, the chamomile, or the lemon balm. It is not recommended. However, it works, especially the fennel, it's work, but we are not sure, as a doctors, we are not sure about the safety and the efficacy. We are not sure about the proper dose. So we cannot recommend that if we don't know these things. What about medication? Long time ago in North America, they used the tincture of opium, and it is very clear for you why it brings them down, because of the presence of the opium. That's why they found it addictive, and it was banned in 2011. What about simethicone? It is not recommended. It's not helping babies. However, we use it sometimes, really just to give the mother something. But study-wise, there is no difference. Acid blockers, not recommended, because GERD is not the cause of infant colic. This was raised for many times, but all studies prove that is not related to GERD. Probiotics is a good choice, but not all of them. Based on the studies, the one highly recommended actually is Lactobacillus reuteri, which I believe is these days is not in our market. Before it was, I don't want to mention the companies, but it was in our market, and nowadays is not there. The other one also recommended is Lactobacillus rhamnosus. So if you have one of those two, you can use it for infantile colic. Thank you.
Thank you so much, Dr. Khaled. If anyone wants to ask anything. So, okay, thank you, Dr. Khaled, for being with us. And you can stop sharing, and we will move to our next speaker. Thank you so much.
Thank you.
Our next speaker will be Dr. Haidar Soumeili, Haidar bin Hussein Soumeili. Dr. Haidar is a consultant neonatologist in King Saud Medical City, and he is the previous chairman of the neonatology unit in King Saud Medical City, Al-Shimisi Hospital in Riyadh. Dr. Haidar will speak to us about the NRB update, the 8th edition. Welcome, Dr. Haidar, and you can start sharing your screen.
Thank you, Dr. Nabil, for this introduction. First of all, I would like to thank Dr. Nabil personally and the scientific committee for giving me this opportunity to talk in this nice webinar. My talk today about updates for the neonatal resuscitation program and resuscitation guidelines. Newborn resuscitation is one of the most frequent procedures carried out in the medicine, and a successful outcome is dependent on rapid response from skilled personnel who is trained very well and have resuscitation skills and updated knowledge in neonatal resuscitation. My talk will go through this outline. Most of newborn make the transition to extrauterine life without intervention. Within 30 seconds after birth, around 85% of term newborns will begin breathe.
دكتور حيدر، احنا مش الصفحات بتاعت حضرتك مش ماشيه، يعني انت في صفحه 5 واحنا ما زلنا على السكرين على الاولى. فاعمل فول سكرين الاول وبعدين
Just a moment.
طيب.
How is it now?
No, still the same. Yeah, yes.
Come back.
Okay. Right.
Is it okay now, Dr. Nabil?
Not yet. You just I can see your screen, but not the presentation.
Wallah, I don't know what is the problem here, Dr. Nabil.
الأول you download the presentation, then open it, and then share from the opened one.
Is it okay, Dr. Nabil? I share it.
Now you shared it, but it is not full screen. But you just start to see. I will see if I will make it full screen.
Okay, I make it now.
No, still not.
I don't know what is the problem, Wallahi, Dr. Nabil.
Can you just go كده, if we'll see if we'll. You are now in page number 5, yes?
Yes.
طيب يلا go to 6. I will see if it will change or not.
I went to Dr. Nabil.
No, still was us, no. مش عارف. Now it is moving. Now it is moving, دكتور شهادة.
Okay, so I make it full screen now. Is it moving now?
No.
Can you send me your email? I'll send it directly. You can upload it from there.
There is, what do you want from me?
If you can open it from your side, because I did my best now, because this is not the first time to present, and I'm usually doing the same, but it is working with me.
Oh, here it's not working, and I cannot see. Can you call Asif كده? Just wait, I will call the media man if he can help us. افتح البرزنتيشن الاول عندك. ايوه كده انت بدات تمشي ماشي. افتح البرزنتيشن عندك وبعدين اعمل شير منه بعد ما تفتحه.
Okay, it is open.
It is open now, yes. Can you move كده we'll see. ايوه now is full screen. خلاص now you are okay.
Okay, thank you, Dr. Nabil, and sorry for the audience. Okay, so this is the outline of my presentation. And most of newborns make the transition to extrauterine life without any intervention. Within 30 seconds after birth, around 85% of term newborns will begin breathing. Around 10% will begin breathing in response to drying and stimulation. And around 5% they will require or need a positive pressure ventilation. And around 2% will require intubation, and less than 1% will receive advanced resuscitation like chest compression or emergency medications. The neonatal resuscitation program and educational program first was started in 1987, and it was specifically designed to address the resuscitation of newborns immediately after birth. After that, in early 90s, started the first edition of neonatal resuscitation program textbook. Then it was updated almost every 5 years, and now in the last update was in 2020, the 8th edition, and the textbook of neonatal resuscitation was released in June 2021. And first teaching we started on the 8th edition. It was on 1st January of 2022. If you go to the guideline development of the neonatal resuscitation program, in the first edition, it was most guidelines were based on the current practice, rational conjecture, and expert of the consultant with little scientific evidence. But since 2000, the evidence supporting resuscitation practice for adults, children, and newborns have been evaluated by the International Liaison Committee on the Resuscitation, which is a multinational collaboration of experts representing resuscitation council from around the world, including USA, Europe, Canada, Australia, New Zealand, and South Africa, as you can see in the diagram. The United States is represented by the American Heart Association and members of the NRB committee who participate on the ALCOR Neonatal Life Support Force. The task force evaluates the strengths and certainty of evidence for care resuscitation questions and release a series of consensus statements. The consensus statements are called consensus on science with treatment recommendation. So these recommendations are used by the American Heart Association and American Association of Pediatrics to conduct and to update the neonatal resuscitation guidelines. And the most recent change was done in 2020. It was part 5, and it was published in Pediatrics and circulation journals. If we go to the neonatal resuscitation algorithm, in contrast to adults, we know that the most common cause of cardiopulmonary arrest in the neonate was pulmonary, and establishing effective ventilation remains the focus of neonatal resuscitation. And the most recent ELCOR, Coaster Summary, and the American Heart Association guidelines have not changed the basic approach to the neonatal resuscitation. And the NRB 8th edition algorithm is largely unchanged. You can see here the algorithm of the 8th edition on the left side, and the NRB algorithm, the 7th edition on the right side. It is the same consequence. We'll start it from the antenatal and preparation and anticipation of the problems, then assessment of the baby after delivery. If you need resuscitation, we'll start by initial steps, then positive pressure ventilation with corrective steps. If you need intubation, then chest compression and medication. But in the 8th edition, there is some changes. We will go through it in the coming slides. There is several practices have been revised in the NRB 8th edition to improve the patient safety and educational efficiency, and it was summarized on this table. There was 6 changes between the 7th edition and the 8th edition. Let us go to the first one, which started by the pre-birth question. In the 7th edition, we were asking about gestational age, amniotic fluid, color, how many babies, and additional risk factors. But in the 8th edition, we replaced the number of babies in utero by the umbilical cord management, because there is a systemic reviews that confirm the safety and potential benefits of delayed umbilical cord clamping in term and late preterms newborns, and also in the preterms infants. The delayed cord clamping for at least around 30 to 60 seconds may improve in late preterm and term the hematological measurements, mainly the hemoglobin, and also there may be benefits for the neurodevelopmental outcomes. However, there may be also an increase because the hemoglobin is increased. There is a chance of needing phototherapy because of hyperbilirubinemia. In preterm infants, the potential benefits of delayed cord clamping include decreasing the chance of needing medication to support blood pressure after birth, like anatropes, and also the requirement for the blood transfusion will be less during hospitalization, and also possibly improved the survival. Also, the intact umbilical cord milking may be an alternative for preterm newborns, but it is not recommended for the newborn less than 28 weeks of gestation, because this may increase the risk of severe intraventricular hemorrhage. The second change from the 7th to the 8th edition was the initial steps reorder. Also, there is no research comparing the order. These steps have been reordered to better reflect common practice. If you can see in the new edition, we'll start by warming the baby, drying, then stimulate, positioning the airway, and finally will end it by suction if needed. And this initial step, it was focused on preventing hypothermia, which is particularly important for preterm infants. If you can go through the evidence to see the effect of hypothermia and early neonatal mortality in preterm infants, this is one of the recent studies. It was published in Journal of Pediatrics a few years back. The number of babies included in this study which was prospective cohort study, it was more than 1,700 babies. The gestational age was ranging from 22 to 33 weeks. There was the hypothermia at NICU admission increased the chance of early neonatal death by 1.6-fold. And the conclusion of this study, simple interventions such as maintaining the delivery room temperature more than 25 degrees centigrade, reducing the maternal hypothermia prior to delivery, providing plastic bags and caps for the newborn infant, especially the preterm less than 32-weeker, and using the warm resuscitation gases may decrease the hypothermia at NICU, and this will reflected in improving the early neonatal survival. To update, scientific reviews has confirmed the importance of using combination of interventions such as radiant warmers with a temperature around 37, plastic wraps, hats, and thermal mattress in less than 32-weeker. When using a combination of these interventions, the newborn temperature must be monitored also to prevent the other side hyperthermia, which can affect also the baby. Ongoing research is evaluating the efficacy of various types of tactile stimulation to support the initiation of spontaneous respiratory effort. To update, consensus support the previous guidelines, which recommended will use gentle tactile stimulation and ensuring an open airway. If the airway is obstructed by secretions, or if the newborn remains apneic and BPV is anticipated, gentle suction of the mouth and nose is recommended, followed by initiation of positive pressure ventilation. The current recommendation regarding the meconium aspiration for the newborn is based on the analysis of 4 small randomized trials that showed no benefit in the prevention of meconium aspiration syndrome or improvement in the survival to hospital discharge from a routine laryngoscopy and tracheal suction, which was done before. But from the 7th edition, we are recommending just only not to do routine intubation and suctioning of the meconium. These 4 systemic reviews was published in 2020, and we can see the conclusion for non-vigorous newborns delivered through the meconium stent amniotic fluid. There is insufficient evidence to suggest routine immediate direct laryngoscopy with tracheal suctioning. And after applying of this guideline, there is studies going to see the effect. If there is anything change after that, this is one of the studies done after that application. It was published in Journal of Neonatology and included a lot of babies, and the conclusion, while the study design confirmation of implementation of the recent NRB recommendation, there was no increase in the incidence or severity of meconium aspiration syndrome following its release. After that, the change also happened on the earlier use of electronic cardiac monitor. Previously, we are using ECG, or we are implementing ECG when we started to do chest compression, but in the recent NRB edition, we are moving now to apply ECG when we are using an alternative airway, either intubation or LMA. Research has shown that half of the errors made during the NRB stimulation are the result of inaccurate heart rate assessment. Even among healthy newborn, clinicians may have difficulty in palpating the umbilical cord, or they underestimate the newborn heart rate on either auscultation or palpation, which could lead to inappropriate intervention, such cessation of the chest compression. In addition, when a team members are required to calculate and report the heart rate, they frequently make both calculation and communication errors. So several studies have shown that an electronic cardiac most accurate way to assess the newborn heart rate during resuscitation. It reports heart rate faster than pulse oximeter and is more accurate than pulse oximetry during bradycardia. Also, an electronic cardiac monitor may be considered for high-risk newborns, even area during gestation, like prematures less than 32-weeker. So the NRB 8th edition textbook recommended that a cardiac monitor should be used to assess a newborn heart rate once an alternative airway became necessary. The fourth changes was simplified initial dose of epinephrine. In the 7th edition, we were using epinephrine through the 80 tube with a dose ranging from 0.5 to 1 ml per kg through the 80 tube, and from 0.1 ml to 0.3 ml per kg if used through IV or interosseous. But now, in the 8th edition, the suggested initial dose, it was in through the 80 tube, use the higher dose, which is 1 ml per kg or 0.1 milligram per kg, while establishing the vascular access. Then after we insert the IV access, or if you are using the interosseous, the initial dose suggested to be 0.2 ml per kg or 0.02 milligram per kg. As we know, the 82 epinephrine, we are giving it while we are waiting for a vascular access. It was unreliable and need to be absorbed to the cardiac, but because of the heart arrest, there is no circulation and will be no absorption. So once we establish the IV access, we have to give the first dose of IV epinephrine. The fifth change was increased flush volume for intravascular epinephrine from 1 ml in the previous edition to 3 ml normal saline through the IV or interosseous in the current edition. The evidence for that, it was from the animal studies that suggests 1 ml, which was used previously in the umbilical vein. The epinephrine, if we flush with 1 ml, it will stay in the umbilical vein or in hepatic circulation rather than going to the heart. So pending additional studies, the recommendation is to give 3 ml of saline, flush either after IV or IO epinephrine. And this single volume will apply to all weights and gestations. There is a question about using it in extreme premature. This will be large amount, but this is the recommendation and we have to follow it. The last recommendation is the expanded time frame for cessation of the resuscitation effort, confirmed absence of the heart rate. Previously, we are cessation after 10 minutes of resuscitation, and now it is recommended to extend it up to 20 minutes. The evidence behind that, failure to achieve the heart rate after 10 to 20 minutes of intensive resuscitation is associated with a high rate of death or severe impairment in the survivor. But identifying the time to stop the resuscitation effort must be a balance the risk of adverse outcome among the survivor with the desire not to cease efforts in a newborn who would have survived with a good prognosis. So based on a recent systemic review, if asystole has been confirmed after all appropriate resuscitative steps have been performed, the NRB 8th edition suggests that it is reasonable to consider cessation around 20 minutes after birth. This will allow the time to complete resuscitative steps and to discuss the decision with a clinical team and with family also. And also behind that, the evidence included in a systemic review indicate that it is often takes more than 10 minutes to perform all appropriate steps. Also, because it is unlikely that any single recommendation for the duration of resuscitation will be accurate, predict mortality or severe impairment in all settings, the decision to discontinue resuscitative efforts should be individualized based on the patient and contextual factors, which including gestational age. So if we are resuscitating a term baby, it is different from resuscitating preterm or extreme premature like 22 or 23 weeker, because the outcome will be different. Also, the presence of congenital anomalies, like lethal anomalies like trisomy 18, or the timing of the prenatal event leading to the birth depression, if it started 1 or 2 days before delivery or just prior to the delivery, and the family's preference and values Also, the availability of post-resuscitation intensive care resources. So if you're resuscitating extreme prematures or baby with congenital anomalies in a setting like a secondary hospital, it is different from tertiary centers in which the resources will be available. That was the 6 changes. And if we go to the text book enhancement, so in addition to clinical practice changes, the textbooks, the new edition, it was included several enhancements to improve the learning, like quick response codes that can be scanned with a mobile device and lead the learner directly to short videos to demonstrate the key skills. Also, they include in this textbook stabilization and resuscitation of congenital defects like myelomeningocele or abdominal wall defect. And also in the 8th edition, the new supplemental lessons that include information about improving team performance by considering human factors, ergonomics, and resuscitation outside the delivery room, like car delivery or in the postnatal or even at home. Now, even the options to participate in the NRB courses, it was changed now. Before, we are giving all the staffs either working with the directly with the neonates or not the advanced NRB. Now we are dividing it into 2 levels: NRB essential and NRB advanced. And this each organization will decide who should have NRB essential and who will have the advanced. The people who will learn the essentials, they will go through the first 4 lessons till the positive pressure ventilation, and people who will learn the advanced, they will go through the all lessons till the lesson 11, including the intubation, chest compression, medication, and resuscitation of the extreme prematures. That's what we talk about the changes. But there is principles that have not been changed. Like program continue to emphasize the importance of anticipation, preparation, and team briefings. Also, the effective ventilation continues to be one of the most important parts of the resuscitation, and most newborns will require resuscitation will recover with effective ventilation of their lungs and will not require either compression or epinephrine. Mask ventilation can be difficult skill to achieve and maintain. Both obstruction and mask leak are common, occur nearly in half of the assisted breath delivered to the preterm newborns. So as a result, it is important to learn and also as an instructor to teach our candidates the implementation of the Mr. SOBA, which is the ventilation corrective steps, which is summarized on this table, started by the mask readjustment and reposition. If there is no chest movement after giving 5 breaths, so we'll go to the suction mouth and opening the mouth. Then if there is no chest movement, we'll increase the pressure in the term baby up to 40 centimeter mercury, and in the preterm infant up to 30 mercury. If this is not effective, so we'll go to the alternative airway, either intubation or laryngeal mask insertion. Also, the NRB 8th edition textbook continues to emphasize using the corrective size mask, either for term or preterm, and correct position of the airway. And we can and to learn how to use the 2-hand hold, which in many studies this significantly reduce the mask leak and give effective ventilation. Also, the use of carbon dioxide detector between the mask and the BBV device can improve a mask ventilation. A team proceed through the Mr. SOBA steps, and if the detector during this process change a color after performing a step, then the newborn heart rate will likely to improve within 30 seconds. But if the color change back to the purple color, that means it is not effective, and this can guide us to recorrect the steps. Also, with corrective mask ventilation is not always successful, and the teams must prepare to insert alternative airway. Also, the intubation from the first attempts, it was low. And the NRB 8th edition suggests considering the use of video laryngoscopy, especially when working with the trainees. The use of video laryngoscope allows the supervisor to provide effective coaching by seeing what the operator is seeing. And among trainees intubating newborn, studies have shown that the use of a video laryngoscope improves the first attempt of intubation. Finally, the NRB 8th edition continues to include laryngeal mask use on a standard list of equipment for more than 32 weekers, more than 1.5 kg. We are using it up to 5 kg. It is a simple device that requires no instruments for insertion, and it can be inserted by any person working with neonates, either clinician, nurses, or respiratory therapist. To end my presentation, I will give you the top 10 take-home message for neonatal support. First one is the newborn station requires anticipation preparation, and most newborns infants don't require immediate cord clamping and or station within the first 30 to 60 seconds, and can be evaluated and monitored during skin-to-skin contact with their moms. Inflation and ventilation of the lungs are the priority in the newborn infants who need support after birth. And a raise in heart rate is the most important indicator of effective ventilation. And as you know, we are working with the neonates. Once the heart rate is improved, the color, the saturation, and the ventilation will improve. Pulse oximeter is used to guide oxygen therapy and to meet the oxygen saturation desire. And chest compression are provided if there is a poor heart response to ventilation after appropriate ventilation corrective stops, which include endotracheal intubation. And the heart response to chest compression and medication should be monitored through the ECG. And if the response to chest compression is poor, this is maybe reasonable to provide the medication, epinephrine, through IV or interosseous, better than the endotracheal route. And failure to respond to medication, and mom is having a history or examination consistent with a blood loss, this is the time to give volume expansions like normal saline or O-negative blood. If all these steps was not effective and the heart rate not response by 20 minutes, this is the time to redirect of care should be discussed with the team and the family to stop resuscitation. This is the end of my talk, and thank you so much. And sorry again for the delay at the beginning.
Thank you so much, Dr. Haidar, for your excellent presentation. I just want to ask, in your institution, what is the cutoff gestational age and weight to start resuscitation?
In our King Saud Medical City, 23 weeker and 400 grams.
400?
Yeah.
Okay. Have you got 400s who passed in a good way?
Wallahi, till now, from 400 to 500 gram, our outcome is very poor, and I think we are thinking nowadays to go back to the recommendation of Ministry of Health, 24 weeker and 500 grams.
Yes, because this is what I just wanted to, that each institute should evaluate his outcome and should take the most accepted weight and age for the facilities or for what's there. And if I will resuscitate.
You are right, Dr. Nabil, you are right. And even I think the whole kingdom, and even the more advanced institute like National Guard or military hospital, our colleagues that are with us, they can share their information. I think still it is 23 weeker. The outcome in Saudi Arabia is very poor.
And here we started, we are still stuck to the 24 and 500, but rarely we took some cases with favorable, or if the family want or insist, we have just 2 or 3 good outcome with 23 weekers, but still the weight is stuck to 500 maximum. If they will decrease to 450, then re-increase again. But below this, the outcome is very poor. And I think that you will just add a handicapped person, even if they will pass, and this will cost the family and even the kingdom a lot of money.
Yeah, you are right. And most of the babies, they will in the first day they will be okay. And you, as you know, you are a senior consultant. A honeymoon period for them. Complication will start from the second day of life. Then they will stay for a few days, occupying the beds, using the whole resources in the unit without any benefit. And less than 10% will survive, as you mentioned, as a handicap babies.
Yes. Thank you so much, Dr. Haidar.
Thank you, Dr. Nabil. Thank you so much.
حضرتك طيب في يوم التأسيس وآسفين على إزعاجك يوم أجازتك.
تسلم يا دكتور نبيل وشاكر على المشاعر الطيبة.
شكرا جزيلا. ألف سلامة يا باشا.
السلام.
So we will move now to our next speaker. Our next speaker will be Dr. Abdelhakim Al-Otay. Dr. Abdelhakim Al-Otay is a senior consultant pediatric urology, and he is the chairman of the scientific committee for pediatric urology in Saudi Council here, and he is one of the members of the American Association for Pediatric Urology. Dr. Abdelhakim is one of the most excellent pediatric urology surgeon I have ever dealt with him. He has made with us very major operations with a good success rate. So he is one of the, I can say, eminent in the world. Welcome, Dr. Abdelhakim, and we are honored to be with us. Dr. Abdelhakim will speak to us about tips and tricks in pediatric and neonatal urology. Welcome, Bash. كل سنة وانت طيب.
السلام عليكم ورحمة الله وبركاته. Thank you very much for this nice introduction. I don't deserve much of this, but inshallah, I will try to meet your expectations. I don't know why this one come here. Are you seeing my?
Yes, I can see. You just yes. Now it's okay. You can go.
It's full screen now. All right. Thank you, Dr. Nabil. Thank you, Saudi German hospital groups, for this nice annual meeting. Really, it is one of the meeting which is developing continuously and keeping with usually, you know, with these conferences and these update courses, it doesn't live long, you know, it takes just once or two. Now we are reaching the 6th or maybe the 7th cycle, doing the update courses with speakers from everywhere in Saudi Arabia and outside Saudi, and with nice information, with too much and huge information in the neonatology and in pediatric work. So, and part of this, I will try to add a little tips and the tricks usually in pediatric urology faced by most of the pediatrician and also the neonatologist who can see these cases. And I found it in my practice during the last 11 years. I was a consultant when I face something, you know, too much and very common. Usually I go in depth with it and asking why this one is happening. Maybe we are lacking some communication, we are lacking some information. And I found this is a good opportunity to expose some of these situation happened to me, and I saw it, and I found if we raise the awareness about it, it will make some changes, I am sure. So, you know, how many girls you have seen in the clinic, you will see there is a recurrent urinary tract infection with many cultures and sensitivities and taking antibiotic. And one of my patient I saw yesterday, this is a patient who is almost now 10 years or 11 years old girl who treated from UTI more than 8 times. And she's having the UTI 3 times, 4 times per year, and taking this antibiotic for 2 weeks, then another urine culture, then after 1 month she will get infected again. So why all of this happening? And I found like the people, they have lacking of taking a full history of this. When I take detailed history, you will see there is a very prominent constipation. I give laxatives, now 5 years without infection. So is it a laxatives is a solution, not the antibiotic? Yes, of course. And this is what's calling, it was called before dysfunction elimination syndrome. Now they change it in the last 3 years to this term, bladder and bowel dysfunction. So why we should discuss this bowel management with a patient with a recurrent urinary tract infection? Because, you know, the bowel and the bladder, they are sharing the same almost embryology, anatomy, a neurological and sphincteric mechanism. So when you look at this, you will see they are sharing almost the same sympathetic and parasympathetic. So when you have disorder in one part, it will have the effect on the other part. And unfortunately, all of us, we know this. And all the pediatricians, they know this, the urologist, the pediatric surgeon, the surgeon, they know this. And we keep treating with just antibiotic, and we did not have a look back to the constipation and why the constipation will cause this. Look at this picture. You will see this picture. I found it good even for my patients when I explain. You will see the nearby and the neighborhood of the bladder neck and the colon. When the colon is loaded, really it has a very bad obstruction and mechanical compression on the urethra. That's why, you know, we got the urine stasis. There is a poor emptying of the fecal retention will direct pressure on the bladder, then bladder instability, poor emptying. The bladder is trying to empty the urine, but the stool is persist and compress the bladder neck, and the urine will stay. And maybe one information, I don't think it's new for you, but for kids only, for children only, if the urine stay in the bladder more than 4 hours, is a good media for bacteria to grow. It's different from the adult who can have urine for more than 12 hours without any problem. But for kids, they are different. They have a very susceptibility to infection. Maybe my colleague in infectious diseases, they know that better than me. But that's why the stasis will cause infection for kids who's holding the urine, who's having the constipation, and they have recurrent UTI. So most of the causes, most common cause for UTI, even here I saw in my practice, I found it from the constipation. 3 days ago, I received a call from one of my colleagues who's a senior consultant in one of the surgical specialty, and really, you know, his daughter is facing the same problem since now 5 years, and there is no treatment. He's treating just with antibiotic, and if they go back and they ask about constipation, yeah, she's badly constipated. She's just having poo maybe every 3 days or 4 days. It's not only in Saudi Arabia, even in Sweden, they have 18% of kids who they have UTI, they have avoiding dysfunction or constipation. Also in Japan is 21%, they have this one, they have good study. In US, they have more than 600 or 6 million who is having the avoiding dysfunction and having recurrent UTI. See how much we can save money from prescribing antibiotic rather than giving laxative, which is very cheap. Maybe it's surprising when you see this study. This is one of the biggest study done in pediatric urology. It's a multivariate analysis of 2,759 child with lower urinary tract disorder or symptoms. They have urgency, frequency, they have cystitis, they have many problems. They found that underactive bladder is having a higher rate of infection. And when they treat a constipation, more than 66%, they improve with just laxatives. UTI improved with laxatives without antibiotic. Why is that? Because the primary source of this one. This is more strange. The other one, about the VUR. You see there is a spontaneous resolution of VUR increased to 1.6 years earlier than the others, and even grade 5 reflux improved with just laxatives, with just treating constipation and time voiding and going to the bathroom 6 times a day, which is the normal and the least normal for kids to go to the bathroom. They should go 6 times a day. Anything less than 6 times a day, we can call it, this is a urine holder child, and he will be very susceptible to infection. This talk is all about the kids who's toilet trained. What about the neonates or about the first year and second year of life? If they have constipation, they will have very bad UTI. They have, sometimes it can reach up to pyelonephritis due to sometimes susceptibility to infection due to the protective mechanism is less for them. So they found the spontaneous resolution increase and the absence of reflux without surgery, just by treating the voiding dysfunction, by behavior and by behavior treatment and by laxatives. So how can we approach this? We have our kids, we have patients, we have with recurrent UTI. Are they really constipated, as you said, or they are recurrent, they have organic problem? If you take a good history and examination about constipation and encopresis, this is the signs. You know what's the problem? You know what's the problem for this? When you ask the father and mother about constipation, is your child constipated? They will say no, even he's constipated. Why? Because the father and mother themselves, they are constipated and they feel this is normal to have to go to the toilet once every 2 or 3 days. So that's why they are just looking at themselves and they answer the question, are your child constipated? No, they're not constipated, because they are the same. So you will see all the family, all the house constipated, and no one knows, because all of them, they thought this is the normal, so we need more awareness. So this is about constipation. All of you, you know that proper, maybe more than me. This is one of the ways I can discover constipation, even if the father and mother denied, is to do X-ray KUB, and you will see the gases and feces filling the abdomen. Also in the ultrasound, you will see this picture. Unfortunately, also, it is missed by the radiologist. They will never comment about this one. You look at this, this is the bladder, and what's under the bladder here? This is the rectum. See, the rectum is loaded with calcified stool. So that's why, see how's the compression on the bladder, and you will not see a radiologist commenting about themselves about this, because they are just looking into the bladder and they thought maybe it's not important, while it is very important. We finish from the first part. Let's go to the other trick or other tips. You see this patient, he was referred to me as bilateral undescended testis and severe phimosis. When you look at this, you will see that both testis is not here and it's not palpable. And when I put the meatus down, it is hypospadic. So we ask for karyotyping. I will ask you why we ask for karyotyping. It became like 46XX, so she's a girl. So this is not a boy. So how come we raise him as a boy and we discharge him from the hospital and we send him to the, sorry, my voice is clear?
Yes, everything is okay.
Okay, good. So we did, so why this one is happening? This is one raised and discharged from the hospital because of the, he just, discharged him from the nursery, referral to pediatric urology due to undescended testis, and that's it. But when you go back to the guidelines and when you go back to the ABC of examining a child, you have this triangle, one testicle, and the external urethral meatus. If 2 of these is not available, so you should ask for karyotyping. What does that mean? If you have a patient with hypospadias and non-palpable one testis, you have to do karyotyping. If you have both testis non-palpable, you have to ask for karyotyping. Even if you do ultrasound and you found this testis as intra-abdominal, maybe lymph nodes, it's not testis. So if you go back for karyotyping should be done for any child who is losing one of these 2 out of 3. So normal EUM, but non-palpable testis. This one is most likely congenital adrenal hyperplasia with the PRADA 5 urogenital signs. So we have to look for it. I'm still, unfortunately, facing cases with babies with, with children who's reaching 10 years, 11 years, who's girls, and they are raised as boys, or boys raised as girls, vice versa, due to poor examination of the child when he discharged from the nursery, or poor knowledge when they discharge him from the nursery. So we'll move to the last part. We are urologists, we like to be quick, we don't want to take much time. So let's go to this one. You will see it a lot in the neonates, which is a perineal mass. You will examine the girl and you will find the mass here in this area. So what is this? This is a differential diagnosis. It will never go out of this 5. Either this is a periurethral cyst, imperforated hymen, prolapse of an ectopic urethrocoel, urethral prolapse, or very, very, very rare is the sarcomatous or a tumor. Sorry, okay, I'm going to the other way. So this is one. This is, you can see here the periurethral cyst. How you will know? You will know when you pass the catheter, you will see the urethra on the side, because this is the cyst coming. And you can see this one. Also here you will see the prolapse urethral mucosa, and you will see it is off center. This is imperforated hymen. You will see the urethra in the tip here. You can see the urethra. This is coming from the vagina, and you can see it in the ultrasound. And this one need to be treated before the patient will go. Here, this is ectopic urethrocoel. I have done a case last week, the same. The urethrocoel is here with severe hydronephrosis, and it's coming. You can see the urethra here, and the urethrocoel is coming through it. And when you do the MCUG, you will see the urethrocoel here. Thank you very much. And this is my talk for this year. I hope it's useful for you and you gain something. I know I am quick, but just to have, for sake of time, I know everybody want to celebrate, especially our people here in Saudis, and they want to finish early. Thank you, Dr. Nabil, again. Thank you, audience.
Dr. Hakim, it's very nice and terrific talk. And I hope that I personally will ask about constipation in every unit. Because we have increasing number of units, when we admit them with fever, with many things, we will find only UTI.
Yeah,
but
exactly.
I don't think we are going deep to analyze the constipation as a cause. Sometimes we are just taking it as the diaper and related to stool and this. But we will go deeper and ask, inshallah. So thank you very much, and for some time, sorry for disturbing you in your شكرا جزيلا. Salam. Now we will move to, you can stop sharing that. شكرا. Now we will move to our last talk today. It will be with Dr. Samira. She will give us a talk about short bowel, an overview about short bowel syndrome, overview, and why it is important in pediatrics and neonates. Dr. Samira Ghalab is our pediatric consultant in Saudi German Hospital, Riyadh, and she is one of the most expert neonatal practicing consultants with us. So, Dr. Samira, you are welcome. You can start. Unmute.
Bismillah ar-Rahman ar-Rahim. My talk will be about short bowel syndrome. I will give heights important for the pediatricians because this issue we met in our unit many times, and every time we will receive short bowel syndrome baby, we will start to research and what we will do and how we will manage, especially the gastroenterologist not with us all the time to give or to put the plan with us. I will start with the GIT parts and functions. I will give definition of the short bowel syndrome, causes, intestinal adaptation, complications, bacterial translocations. And then I will have some slides about small intestinal bacterial overgrowth and the prophylaxis for patients with risky for this with short bowel syndrome, risky for small intestinal bacterial overgrowth. So some infants and children undergoing intestinal surgery are risky to have intestinal resection of variable length according to the situation. For example, we have post-volvulus causing gangrenous part of the intestine, and in case of severe neck in the ICU, either perforated or not perforated, surgeon may have to resect variable parts from the intestine. And he may do a ileostomy or jejunostomy according to the area of the perforation or the extent of the inflamed or gangrenous part. So then sooner or later, some of these patients may have manifestations of short bowel, either will adapt with time or they will not adapt and will depend on the parenteral nutrition for their life, or they require intestinal transplantation. I have give an overview about the function of the parts of the small intestine. The most important area for us issues that is the terminal ileum is responsible for the vitamin B12 deficiency and bile acid and bile salts absorption, vitamin B12 absorption and bile salts absorption, and the importance of the ileocecal valve that is preventing the translocation of the bacteria from the colon to the small intestine and regulating the passage of the intestinal contents to the cecum and colon. The intestine in general is responsible for all the parts that have a role in the water and sodium absorption, but the most important, the most part, including this, is the colon. And the small intestine, proximal small intestine, is the mainly responsible for the absorption of proteins, carbohydrates, and fats. Then I will give idea about the length of the small intestine, because usually the surgeon will come and tell you, I removed or resected from the intestine 20 cm, or he will tell you, I left for the baby 20 cm in the ileum, or whatever. In infants, the normal length of the small intestine is approximately 125 cm at the start of the third trimester, and at term gestation reaching about 250 cm. And in adults, length is variable between 300 to 800 cm. And infants with residual small intestine length of less than 75 cm are at risk for developing short bowel syndrome. Actually, if this length is present with preservation, even if 50 cm present with preservation of the terminal ileum and the ileocecal valve, this patient will adapt and overcome the manifestation, and they have a very good prognosis. The jejunum occupies the proximal 2/5 of the small intestine, and the ileum consists of the distal 3/5. So, why the ileum is important? Retaining all or part of the ileum is advantageous for several reasons. The first job or function of the ileum is its role in the adaptation. Although the proximal small intestine is primarily responsible for the absorption of proteins and carbohydrates and fat, the ileum has a remarkable ability to adapt and compensate for the absorption of these nutrients after loss of the jejunum. The ileum has a greater capacity for intestinal adaptation compared to the jejunum. That is the meaning of these words. Fluid absorption, it is a second importance of the ileum, because if the ileum is removed, usually these patients will have watery diarrhea persistent. Specific nutrients absorption, especially vitamin B12 and bile salts. And if deficiency leads to malabsorption of fat and fat-soluble vitamins. The third function is the barrier function, the function of the ileocecal valve that is regulating the passage of the fluid and nutrients from the ileum into the colon and preventing the passage of the anaerobic bacteria from the colon to the intestine. For the remark is that infants with less than 30 cm of small intestine or small bowel and lacking the ileocecal valve are less likely to be weaned from the parenteral nutrition and less likely to recover unless they, and usually these need intestinal transplantation. The colon has the greatest deficiency of water and sodium absorption, as we told in the previous slides. So the short bowel syndrome clinical disease is only weakly correlated with the amount of intestine that is resected because of the highly variable length of the human small bowel and the remarkable ability of the bowel to compensate for bowel resection. Significant malabsorption of both macronutrients and micronutrients are present in these patients, and it has nutritional, metabolic, and infectious complications. Short bowel syndrome is the most common cause of intestinal failure, which is defined by or states when an individual's gastrointestinal function is inadequate to maintain his or her nutrient and hydration status without intravenous or enteral supplementation. The short bowel syndrome classified to two. Short bowel syndrome, the usual one that is defined when people have lost more than half of the length of the small intestine. The ultra short bowel syndrome refers to those who have less than 25% of small bowel remaining. So the causes of short bowel syndrome, congenital anomaly, such as omphalocele gastroschisis or intestinal atresia, post-surgery. Usually this patient underwent surgical resection of significant part of the intestine, or there is significant word gangrene, especially in the omphalocele and the gastroschisis cases. Necrotizing enterocolitis associated with prematurity. It is frequently seen in the ICU. And this patient, if underwent for surgery and resection done for part of the intestine, especially if they did, for example, proximal ileostomy or jejunostomy, until recovery of the distal part of the intestine, the time waiting for the recovery, these patients will have the manifestation of short bowel syndrome if they didn't managed properly. Intestinal ischemia from malrotation and the volvulus, Crohn's disease, and rarely some cases are genetically have short bowel. Complications of short bowel including nutritional deficiency, carbohydrate, proteins, fat, vitamins, minerals, malabsorptive diarrhea, dehydration and electrolyte abnormalities, gastroesophageal reflux, failure to thrive, hepatic affection, drug toxicities, sepsis, central venous catheter infection, and small intestinal bacterial overgrowth. Once you have a case of short bowel syndrome, you should include the gastroenterologist and the dietitian with the IT subspecialty in the plan of management. So how to overcome these complications of short bowel syndrome? The most important issue here is to help intestinal adaptation. Intestinal adaptation is the process following intestinal resection, whereby the remaining bowel undergoes macroscopic and microscopic changes that serve to increase its absorptive ability. And the best established stimulant of intestinal adaptation is the presence of nutrients in the intestinal lumen. Nutrients requiring digestive processing prior to absorption serve as important stimuli for intestinal adaptation, such as disaccharides and long-chain fat. Those stimulate adaptation more than the monosaccharides and the medium chain fat. Omega-3 fatty acids also have a beneficial role in inducing adaptation in the small intestine and the colon. The patient with short bowel syndrome, this patient in the start, after the operation, the few months after the operation, these patients have hypergastrinemia, and they need to put in schedule for H2 blocker or PPI for a few months. Then after that, they can stop the PPIs or H2 blocker. And this will help in intestinal adaptation. Also, was observed that prostaglandins stimulate the intestinal proliferation, so we are avoiding to use the non-steroidal anti-inflammatory drugs, the aspirin and the steroids for these patients. Regarding the nutrition, good nutritional status through administration of parenteral nutrition and the prevention of fluid and electrolyte abnormalities in patients who will likely require parenteral nutrition for more than 3 weeks, we should restrict the soy-based intravenous lipid solutions to a dose of 1 gram per kg per day. Actually, the persons in general or the human being can live without deficiency of essential fatty acid if he is taking 1 gram per kg per day for 3 days per week. يعني about 0.25 gram per kg per day. It is sufficient to have the essential fatty acids from this. Enteral nutrition, we should quickly initiate enteral feeding for all children with short bowel syndrome. Even because enteral feeding is supporting the intestinal adaptation, and usually it is preferred to start with breast milk. And if the breast milk is not available, we are starting with amino acid-based formula. And we typically use continuous OGT or NGT feeding. And we're starting usually with small amount according to specific protocol for increment of the feeding. For rising that the patient typically require, this patient typically requires about 30 to 70% more calories if they are fed enterally compared with their energy needs from the parenteral nutrition. About parenteral nutrition that we can give through about maybe 90 to 110 or 120 calories per kg per day maximum. Enteral feeding, we should give more calories reaching to 140 to 100, maybe can reach to 200 calories per kg per day. So we should have protocol to increase the enteral feeding, and this will be according to the condition of the patient. For example, if patient has ileostomy or jejunostomy, if there is jejunostomy, this patient usually has watery diarrhea. Sometimes you are putting the milk from the OGT, the milk will come from the jejunum. And this patient usually are trying to, if there is remaining intestine down, we are trying to minimize the period between the first surgery and the second surgery to make a connection again or anastomosis after the healing of the intestines for cases, for example, with neck. We should calculate the output through the ileostomy or jejunostomy, and according to the output, we are adjusting the feeding. If we are starting feeding, we may start with between 0.25 ml per kg per hour, 0.25 ml per hour milk, amino acid-based or breast milk, up to 1 ml per hour. And this we can, sometimes we are staying for this for 3 to 5 days, then we'll start to increment. Sometimes we are starting 1 ml, then we are giving increment daily according to the tolerance of the patient, according to the severity of the short bowel syndrome. If the output from the ileostomy is more than, for example, the normal output for the intestine, for the stool is about 20 to 30 ml per kg per day. If it is more than this, we should either replace, or sometimes we have to stop the feeding or decrease the feeding or stop the increment of the feeding until the output will be adjusted. It is imperative to provide small oral feeding at age-appropriate intervals to allow for development of sucking and swallow reflex and to prevent oral aversion, even if only small volumes are tolerated. And this practice we should apply for the newborn, for the preterm babies that we are giving OGT feeding. We should, if they can't take oral feeding, we should apply for them drops, even if drops only orally. These drops will activate the enzyme and the hormonal secretions that is in the mouth and the esophagus. And these are very important for the tolerance of the feeding rate. For reaching half the amount or calories of enteral feeds, some centers they can shift to bolus feeding, but actually in our unit we are using the continuous feeding until we reach the full feed. Then we will gradually shift to bolus feeding. Of course, when we are increasing the feeding, we will decrease the parenteral nutrition. But some patients are eventually able to win from parenteral nutrition, but continue to need parenteral fluids to prevent the dehydration and electrolyte imbalance. And this patient usually does have small part of the ileum remaining, because the ileum has good job regarding the absorption of the water. And if the ileum is absent, especially the abdominal ileum, this patient have watery diarrhea. بيسموها bile acid diarrhea.
اللي بيكتبوا الارقام والكلام.
Cycling parenteral nutrition, this one depending on that if the patient is older, يعني older infants and children, they give time for freedom to practice their normal life. So we are giving parenteral nutrition for less than 24 hours and preferring to be during sleeping time. But this patient, we should follow the dextrose because they are liable for disturbance in the blood glucose level. It is important to know that the important elements of chronic enteral nutrition are diet that is reasonably balanced mixture of fats, proteins, and carbohydrates. Avoid a hypertonic diet and simple carbohydrates. Monitor and replacement therapy for micronutrient deficiency. Lab investigations, there is a schedule for, we are putting the schedule for the lab investigation for this patient. Some investigations will be done weekly, like a comprehensive metabolic panel, CBC, triglycerides, cholesterol, and bi-weekly, twice per week, electrolytes, blood urea, nitrogen, creatinine, calcium, magnesium, phosphorus. Monthly, we are doing folate, vitamin B12, vitamin E, copper, zinc, and selenium serum levels. As we know that the vitamin B12 deficiency and can cause and folate deficiency can cause macrocytic anemia. And this patient, especially the patient have bacterial overgrowth, they will have iron deficiency anemia. Onset of refractory, some patients have refractory normocytic anemia. And if we found this anemia, we should consider the multiple micronutrient deficiency, including iron, vitamin B12, folate, and copper. And we should start to replace these micronutrients. If we suspected sepsis, we should have blood culture from both the central line and peripheral sites, urine analysis and blood culture specifically to search for the fungal infection. And if there is recurrent or persistent fungal infection, we must have abdominal ultrasound to search for the fungal walls in the kidney. If we are suspecting localization or abscess in the intestine, we should do the CT scanning of the abdomen to detect it. If suspected bowel obstruction, which is common to happen in later infancy and early childhood, for the patient underwent surgical operations because of the adhesions, we should do the plain radiograph of the abdomen, barium imaging of the bowel if needed. So in the follow-up, this patient may have need to keep the hydration status neutral. They need regular vitamins and mineral supplementation. The antacids should be not abused. It will be needed for the first few months only after the operation, then should be discontinued. Low salt diet if renal stones developed, and the antibiotics. And we'll speak later about the antibiotics regimen for the prophylaxis in cases of short bowel syndrome, risky for small intestinal bacterial overgrowth. طبعا these patients need intestinal rehabilitation programs with multidisciplinary team work up. They may have small surgical transplantation, small bowel transplantation may be needed if they have intestinal failure. So next few slides, I will talk about small intestinal bacterial overgrowth. Before this, I will talk about the intestinal flora. In humans, the gut flora is established at 1 to 2 years after birth, by which time the intestinal epithelium and the intestinal mucosal barrier have co-developed in a way that is tolerant to and even supportive of the gut flora, and that also provides a barrier to pathogenic organisms. The gut flora has multiple functions. The first one is endocrinal function. It has absorptive function. It has synthetic function for vitamin B and vitamin K. It has metabolizing bile acids, sterols, and xenobiotics. If there is dysregulation of the gut flora by any cause, these patients will have inflammatory and autoimmune conditions. The intestinal flora are mainly bacterial. Some fungi, protists, archaea, and viruses can be present, but little. These bacteria represent between 300 and 1,000 different species, but 99% of these bacteria come from about 30 to 40 species only from this number. Over 99% of the bacterial flora are anaerobes, and the large intestine is has the large percentage of this bacteria, also about 99%. But many of these bacteria we can't culture in the lab. We'll take from the intestine part by part regarding the organisms that they have. The stomach has high acidity. فالبacterial growth, if happened, it will be very small and minimal. Strep to Staph or Helicobacter pylori. The proximal small intestine, still there is effect of the stomach acidity reaching the proximal intestine. You will find some trace bacterial flora, gram-positive foci and rod-shaped bacteria are the predominant. The distal small intestine, the main is Enterobacteria. But the microbiology of the terminal ileum is different because it is nearby taking the characters from intermediate zone between the aerobic flora that is found in the stomach and the proximal small intestine and the dense population of anaerobic organisms found in the colon. The colon contains the largest bacterial ecosystem in the human body, and as I told, 99% of the large intestine and feces flora are made up of obligate anaerobes, such as bacteroids and bifidobacteria. So the small intestinal bacterial overgrowth is a condition in which the small bowel is colonized by excessive aerobic and anaerobic microbes that are normally present in the colon. Means that it is the normal flora that is present in the colon become overgrowth, and this causing manifestations of sepsis or intestinal infection. Normally, the host mechanisms protect against excessive small intestinal colonization by bacteria. This host mechanisms includes the digestion by the gastric acid bile and proteolytic enzymes, intact ileocecal valve, antegrade motility pattern of the ileum that inhibit retrograde translocation of bacteria, and the secretory IgA, which aids in the preventing bacterial proliferation. The risk factors for bacterial overgrowth includes anatomical factors, functional or multifactorial risk factors. The anatomical factors includes either congenital or acquired, and the congenital including jejunal-ileal webs, small bowel atresia, gastroschisis, omphalocele. Acquired abnormalities, for example, including perinatal obstructive condition, as seen in necrotizing enterocolitis, midgut volvulus, and ischemia. The functional risk factors include either intestinal dysmotility caused by strictures or adhesions or mucosal inflammation, or the loss of protective gastric barrier as found in Helicobacter pylori infection, proton pump inhibitor or overuse, hypochlorhydria, and total or subtotal gastrectomy. The multifactorial category, including the immune deficiency, malnutrition, chronic pancreatitis, and parenteral nutrition dependence. The concept of bacterial translocation. Bacterial translocation is the movement of gut origin microbes across the intact gastrointestinal tract into normally sterile tissues where the organisms may then directly cause infection or precipitating an inflammatory process or inflammatory response that causes tissue injury, organ failure, and death. So the causes of sepsis in these patients will be bacterial translocation. And these patients also are liable for bacterial translocation from the skin through the central catheter if present. Culture of diagnosis of the organism includes culture of the direct aspirate of the small bowel contents, especially from the duodenum, and hydrogen breath test. In spite of this, both have false positive and false negative interpretations. But for the diagnosis in general, you should have more than 100,000 colony-forming units of bacteria per 1 ml of duodenal aspirate on the culture. Any suspicion of sepsis necessitates blood cultures. Children with short bowel syndrome are susceptible to intestinal bacterial translocation, with the central line as the most likely source of seeding. They are also susceptible to translocation of skin flora, such as staph species. This site of blood culture must have from the central line and from the peripheral line. Consider opportunistic infections by fungal infection. And obtain urine analysis in the blood culture to detect a fungal urinary tract infection. So we'll shift now to the treatment and the prophylaxis for small intestinal bacterial overgrowth. The bacterial overgrowth often recurs and requires prolonged treatment, including sporadic or periodic antibiotic therapy. The risk of long-term antibiotic therapy, tolerance, extent of systemic absorption, and bacterial resistance must also be considered. Proton pump inhibitors, H2 receptor antagonists, and antidiarrheal should be used with caution because decreased gastric acidity and motility may promote the bacterial overgrowth. And it is important to correct the nutritional deficiency. These pro-motility agents, sometimes we have to use. If we diagnose bacterial growth, we can use this pro-motility to increase the excretion of the bacteria in the stool, erythromycin, amoxicillin clavulinate, and cisabride. But consider that is cisabride, azithromycin are causing prolonged QT interval in some patients, so we must have family history before we start this. So the prophylaxis, including also for central venous catheter infection, these procedures include chronic ethanol lock or antibiotic lock. Some now they are not using antibiotic lock in general. Ethanol lock can be applied using techniques installing alcohol ethanol 70% to dwell in the catheter when it is not being used for parenteral nutrition. Prophylaxis against bacterial growth, we administer antibiotics on a periodic basis, 5 to 10 days out of every month or every other week, according to the pulse of each unit. Antibiotics are changed to prevent the development of resistance to a specific drug. The frequency and with which antibiotics are rotated varies from monthly to every 6 months. This the category of antibiotics that can be used for the prophylaxis: trimethoprim with the doses, trimethoprim, metronidazole, amoxicillin clavulinate acid, tetracycline rifaximin, fluoroquinolones, ciprofloxacin, amino glycoside antibiotics, gentamicin, and neomycin. This picture is showing the use of cyclic antibiotics according to the severity of the risk for bacterial overgrowth. For example, for empirical treatment for moderate risk patients, اللي هم defined as those with no radiological or clinical evidence of this motility, or radiological evidence meant by for example, presence of dilatation of the bowel or much gases in the bowel, our clinical evidence, for example, distension, whatever. We are using comprises a 7-day gentamicin. This is 7-day antibiotic, gentamicin, for example. You can choose the antibiotics according to the availability. Gentamicin, 7 days, metronidazole, 7 days off. This is for the moderate risk bacterial overgrowth. 7-day antibiotics, then 7-day off. Those for high-risk patients defined as radiological evidence of this motility, such as dilated bowel, and or clinical evidence of this motility, such as gastroschisis, is comprised of cyclic oral, for example, gentamicin and metronidazole for 7 days. يعني alternating by 2 medicines only, gentamicin and metronidazole, for example. طبعا الانتيبيوتكس should be changed every, as I told in the previous slide, that you can change every 1 month or every 6 months. You can change the schedule of the antibiotics you are using. If patient have high risk for bacterial growth with recurrent infection or line infection or worsening cholestasis, the antibiotic cycling will be all the time. 7 days Genta, for example, 7 days metronidazole, 7 days amoxicillin clavulanic acid. Then repeat the cycle. The prognosis, as long as the ileocecal valve and terminal ileum are saved, the prognosis is good. Adaptation is excellent for the ileum than the jejunum. Close monitoring and early detection of infection and aggressive prevention of bacterial overgrowth in cases with short bowel will likely improve the prognosis. Short bowel syndrome in infants and children had a high mortality, and 1/3 of patients could adapt, requiring up to 5 years of care and management. The message here is short bowel syndrome has clinical manifestations resulting from variable intestinal length resection. Ileocecal valve and terminal ileum, if saved again during the intestinal resection surgery, result in a good prognosis. The ileum has a great ability to adapt. In adaptation, this remaining part of the intestine will have macroscopic and microscopic changes and will grow and increase in length with aging of the child. Helping early adaptation is a critical issue, and the most important helper is early enteral feeding and nutritional supplementation. If proximal ileostomy or jejunostomy with manifestation of short bowel, closure and anastomosis, when possible, as early as we can improve the condition of the patient. The main management of short bowel is hydration, nutritional, treatment of minerals and vitamin deficiency, prevention of bacterial overgrowth. If the patient has moderate or severe risk of bacterial overgrowth, they should receive cyclic prophylactic antibiotics according to written protocol to each unit. Short bowel syndrome patients may adapt in up to 5 years of age, so we should patient with this patient and treat, because after 5 years they maybe go in a normal lifestyle. This was last slide. Thank you.
Thank you so much for your informative lecture. If anyone wants to ask. So with this lecture, we will reach to the end of our, just wait. Okay, with this talk, we will end our second day of the symposium, and we hope to continue in the morning, inshallah, with our last day, hoping that this day was beneficial. I thank very much our respectable speakers, and again for our Saudi consultant who shared us in their National Day. Thank you so much. Thank you so much for all attendees who beared with us and stayed till now. Hoping to see you tomorrow to continue our scientific program. Thank you and Assalamu alaikum.